I feel like it's school.
Good morning. Can everybody hear me? I'm Barnett, and I'd like to welcome everyone to our 6th annual Health Reform Seminar on behalf of the Greater Hall Chamber of Commerce. I'd like to thank you all for coming out on a wet Thursday morning, early in the morning. Hope traffic wasn't too bad. But before I start, I would like to say that we do express our sympathies for the people down in Houston and the entire Gulf region, because we're experiencing some rain today, but nothing like they have. So please continue to keep them in your thoughts and prayers, and if there's anything that you can do to reach out and help and support our neighbors to the south, please do so. But at this time, like I said, it's our pleasure to host the 6th annual Healthcare Reform Seminar. A lot has changed in the last 6 years. You know, what kind of started this off is the Affordable Care Act and all of the laws and regulations that came about because of that act. There have been some changes. We thought there'd be more changes, and there could be more changes to come. But there's one thing that's for certain, is this is going to be around probably in some sort of form or fashion to affect a lot of our businesses going in the future. And one thing to keep in mind is a lot of you may be larger employers that are directly affected by this act. However, there are a lot of smaller employers that, as the economy begins to strengthen, these businesses begin to grow, and their employment base and their size is going to bring them into purview of this law and all of these regulations as well. So people could be reaching out to you, asking you questions: how did you adapt, how did you conform, and how did you comply? And so I think you'll enjoy the program this morning, because it's going to have a little emphasis on a look back and the compliance, and also how to keep some of our employees healthy, because I think we'll all agree that a healthy employee is a productive employee. And with the unemployment rate as low as it is in Hall County, we need to keep all of our employees as productive as possible. But this program would not be possible without the help of our generous sponsors. I'd like to thank all of these at this time: Turner Wood Smith Insurance, North Georgia Health Systems, Vision 2030, Brenau University, ProCare RX, Humana, and Rushton CPA. So let's please give these sponsors a round of applause. And again, we would like to thank Brenau University. They are a generous host, and they allow us to use this auditorium every year, and they've been very supportive of us. And in a minute, Dr. David Miller is going to come up and give a synopsis of the program this morning, some of the logistics and housekeeping, and how the program will be run this morning. But before that, Dr. Ed Schrader could not be here this morning, and in his place, welcome from Brenau University will come from Dr. Schrader. Please join me in welcoming Dr. Schrader.
Good morning on this bit of a soggy morning. Dr. Miller and I are going to tag team here while he does the IT stuff. I do not have a slide presentation. I want to take this opportunity to welcome you to one of the 4 campuses in the colleges, the College of Health Sciences. And those of you who know our university know that we've been really hand in glove with trying to address a lot of the economic drivers that really help this community in this state. Dr. Miller and I have collaborated for many years working on developing his new undergraduate program in healthcare administration. We've had an MBA in healthcare administration for quite a while. And in health sciences, if you've been here a while, you've seen us grow from one of the smallest colleges at Brenau to now the largest college, offering clinical doctorates. Our doctorate in physical therapy is offered in this program, doctorates in occupational therapy and nursing, all the way down to our entry-level BSN program that's over 50 years old now. So we're very proud of that program. It's so important that we continue to address the changes and needs, particularly of our community employers. And so we're very happy to have you here. And one of the things I know you're going to be hearing about today is something near and dear to our heart, which is a move towards wellness, to move away from the disease model into a wellness model. So again, welcome to our university, welcome to our beautiful home here, and hope we can see you here multiple times, hopefully not as a patient. So welcome again, Dr. Miller.
Thank you, Dr. Sterich. Okay, well, as some of you know, my name is David Miller. I'm a business professor here at Brenau.
I'd like to thank Dr. Stewart.
There he is.
Sorry.
That's Dr. Schrader, president of the university, and my boss. So anyway, I'd like to welcome you back to the 6th annual Healthcare Reform Seminar. And yes, indeed, we are at it once again. Some of you might remember when we first started the seminar, I had jet black hair and weighed 170 pounds. So some things have changed over the last few years. Since the ACA was signed into law in 2010, I don't think anyone would deny that it's been an interesting, somewhat chaotic ride. This is especially true for those of you in the audience who own your own business or are charged with implementation of the regulatory mandates accompanying the Affordable Care Act. The employee benefits landscape continues to evolve, with the ACA influencing the way employers fund and deliver benefits programs. As you can see from your agenda, we'll kick it off today with the talk which will give us an update on healthcare reform and help us all plan for what the ACA has in store for us in 2018. Where's Brett Fowler? There he is. Good luck, Brett, and I hope you brought us your best crystal ball. So we'll kick off with that. Then, Rob Fowler, Executive Vice President of Turner Wood & Smith, will moderate our distinguished panel of compliance experts discussing, quote, employers' greatest fears, PPACA and compliance. This is a timely panel, since when examining the large employer market, the American Health Policy Institute showed a 4.6% increase in 2016 compliance-related activities, and by 2023, a projected 8.4% increase over and above what they would otherwise be spending in direct compliance-related activities. That's for the large employer market. I can't imagine a scenario in which the regulatory burden as a percentage of overall operating budget for small and mid-sized companies will not be at least as much, if not significantly more. That doesn't make you sit up and take notes of what the panel has to say. I don't know what will. We'll finish up the morning with a talk by Dr. John Montgomery, VP and Chief Medical Officer for Humana, on employer wellness strategies. Employee wellness and the associated wellness programs are not only offered to assist employees with improving their health status, but are becoming an essential recruitment tool for potential employees who are millennials or even Generation Z. And you might not know this, but Humana has a distinction of being in the PPACA. Does anyone know what the PPACA is? All right, well, that's the big five of healthcare insurance companies. Say it with Blue Cross, United, Cigna, Aetna, and Humana, right? The PPACA. Jay Andrews said that reminded him somewhat of the five families of New York, but we won't go there, okay? And if you remember PPACA, right? If you remember PPACA, you pass the quiz at the end of the day, and since it's the beginning of the semester, everyone gets an A. Okay? Should be a great morning with plenty of interesting and important information provided. I want to thank you for coming, and please feel free to contact us if we can do anything to make the morning more enjoyable. A couple of logistics. Restrooms are out the door in the back and to your left. And please remember to take your cups and whatever you have, plates, with you when you leave. I was asked, Perry was supposed to do this, but just to remember, for those of you who stay the entire seminar, we'll have door prizes, including, I think there's a bike out there, there's a Fitbit watch, there's all sorts of fun things, umbrellas and Apple Watch, all sorts of things. So stay till the end and be in the running for one of the great door prizes that we have. I'd like to turn it over at this point in time to Brett Fowler from Turner Wood & Smith to give us an update on the Affordable Care Act and what we have to look forward to in 2018. Brett.
Alrighty. It's hard to believe it's already been another year, but I've got a lot of information to cover in just a short amount of time, so we're going to jump right into things with the Affordable Care Act in today. So I'm going to give you a little bit of a timeline on what's been going on. As you know, not a whole lot of changes. There are some projected changes, didn't quite pan out, but let's kind of go through it from a timeline to keep you up to date on where we are today. January 20th of 2017, as expected, with President Trump coming into office, signed an executive order. This was more of a warning shot, saying that the ACA was going to be something that would be the first thing that would be tackled. It leads us in, all the way down to May 4th, where the American Health Care Act, better known as the AHCA, narrowly passed the House 217 to 213. This pushed things over to the Senate, where they drafted the Better Care Reconciliation Act, and that went and passed on for a couple months. Couldn't quite muster up enough support there, and so that was abandoned at that point. That gets us into mid-July, where talks of a skinny repeal were taking place. On July 25th, there was a vote that was 50-50 with Vice President Mike Pence breaking that tie-breaking vote, led us into a long debate that ultimately ended us on July 28th with a vote that fell by 51 to 49. That skinny vote would have been known as the Healthcare Freedom Act. It really would have eliminated the individual mandate, the employer mandate. For HSA plans, would allow the out-of-pocket maximum to, you could have contributed enough to your individual or family plan to meet the max out-of-pocket. So would have been some changes there, but of course, those were not passed. And so that effectively ends the current efforts on the repeal and replace. ACA remains the law of the land. It's the current law. And you as employers must continue to comply with the provisions that are laid out from the Affordable Care Act. From the Republican standpoint, they've noted that they're going to focus on other legislative issues, but we know that they do remain committed to repealing or to trying to make some type of change to the Affordable Care Act. The Senate, on the other hand, they had the option to reintroduce the skinny bill or a version of it. But what we really think here that we're probably going to see more likely is probably some bipartisan legislation that might take place. An example of that could be, the Republicans have noted that they would love to get the full-time hours back up to 40 hours. That's highly unlikely, but maybe somewhere in the middle at 35 could be something that's worked out, and we could see some working together there. The first thing that's going to take place, though, in September that's the most important, particularly for the individual market, is the cost-sharing reduction subsidies. So right now, an individual in the market that is making between 100 and 400% of federal poverty level is eligible for a subsidy. So they get a financial subsidy based on their income. But if their income is low enough, they also have the ability to get a cost-sharing reduction subsidy. And what that does is if they have a silver plan, it effectively helps pay for some of the deductible associated with their plan. There have been talks, if that is not funded, that the individual rates would go up as much as 20 to 25% on top of what they're already going up this year. So we're going to see both parties there making sure that is something that stays in place, or that could really turn the individual market upside down as far as rate increases go. So that's something to keep in mind that'll take place in early September. I think that somebody wants to give us an update. All right. Well, to move us right into the exchange open enrollment, I know that many of you in here today are employer groups, but I know we have some individuals and some small groups. we still thought it would be relevant to keep you updated. You might have employees in your population that have family members that need to purchase policies through the exchange, and just so you know what's going on with the market, we'll talk about the actual open enrollment time frame. So individual open enrollment time frame starts November 1st, and it will run through December 15th. For those of you that know, in years past, this has gone all the way to January 31st, so it's effectively been cut in half, the number of days that you have to enroll. If you enroll by December 15th, coverage will start on January 1. And while 45 days is plenty of time to get the individual plan signed up for, everybody knows those procrastinators, and there's going to be people that do not know that this is coming down the track. And if you do not sign up by December 15th, the only chance of getting a plan through the exchange or an individual marketplace will be if you have a qualifying event after that. So who qualifies for subsidies? We talked about this just a second ago a little bit, but it is somebody that falls into 100 to 400% of federal poverty level. That for this year, just over 12,000 to 48,000 for an individual, and 24 to 98,000 in those ballparks there for a family of 4. Of course, if you're on the lower side of those income levels, then the subsidy is going to be much larger. As you start reaching that 400% of federal poverty level, then the subsidy will dwindle and it'll be minimal at that point. To give you a recap on the 2017 enrollment numbers, at 8.7 million people in the marketplace, with 84% of those receiving subsidies. So overall, the large majority of them getting a subsidy. As we talked about the cost sharing reduction subsidies, 59% of those people are getting a cost sharing reduction subsidy as well. And then about 71% of what's being purchased on the market is a silver plan. As I noted earlier, you have to have a silver plan to get that cost sharing reduction. So seeing that 59% of the population is getting a cost sharing reduction, they're in that silver plan. The other 29% here that we're talking about that don't have a silver plan, you have a few that are out there with a gold plan that are maybe buying their plan individually, know that they are going to meet their deductible. But the overall majority of that is in a bronze level plan, just trying to get the cheapest plan that they can to meet the requirement. We have the penalties will be staying intact for 2018. The penalty didn't change from 2016 to 2017. Could change slightly, maybe with adjusted for inflation for 2018, but the penalty that you would pay in 2018 for not having coverage in 2017 is the greater of 2.5% of your yearly household income, or $695 per person. The fee is prorated based on how many months that you're without coverage, but if you were without coverage for the entire year, then that penalty would be assessed over the 12-month period. One individual mandate exemption, you could, if your income for 2018, if the cost of insurance would be more than 8.05% of your household income, then you do not have to take a plan, and you're not going to have to pay a penalty for not having coverage, but you would be without coverage, and so effectively that's still not a good place to be in. But that would, an individual would not be getting a penalty for that. We often get questions on, how is the penalty assessed? What is it looked at? They look at the adjusted gross income, and the penalty is on the amount above the tax filing threshold. So for an individual, that's $10,350. So a penalty that's going to be assessed is going to be on your income above that amount. And then the most that the penalty can be is the national average for a bronze plan. So an individual bronze plan for this year is $272 per month. That is up tremendously from the year before. That's an annual penalty of $3,264. So that would be if an individual was on the higher income level, and that would be the max that they could pay in the form of a penalty. Now for a family of 5, the national average for a plan cost is $1,360. Up almost $250 from the prior year, and that annually is $16,320. So that is the max that a penalty could be, for the year. We've got a lot going on in the individual market in 2018. Been a lot of things in the news, newspaper, online, wherever you are, you're probably seeing it. There was worried that there were not going to be an insurance company in every county for the exchanges. As of 2 weeks ago, there were still 82 counties in the United States that were not going to have a health insurance company participating in the exchange in their area. The good news is that over the last week, that number has dwindled to 0. So there is an insurance company in every county for the exchange across the United States as it stands today. But the one thing to note on that is that, with the Affordable Care Act, one of the things that the goal was to increase competition. And one thing we've seen is that it's been more or less the opposite of that. Right now, there's over 70% of the counties in the United States that will only have 1 to 2 participants, insurance companies in their area to choose from. And that specifically will apply to Georgia as well. So we'll talk about Georgia's numbers from the open enrollment standpoint. Georgia had just under 500,000 people enrolled in private plans. These are people that were new enrollees and renewals. 87% of that population is receiving a subsidy, with the average price being right around $431 a month. But with those subsidies, it's taken the premiums down to $122 a month. So, a lot of that cost share is passed along, in the form of that subsidy. As far as the penalty payout goes, these are numbers from the IRS through April 27th of each year. And I know these numbers can fluctuate, so it'll be updated, but just on the people who've paid penalties, and the average penalty was $708, so very close to that $695 threshold. One thing to note about individual plans, and we'll talk about this, but is that the increases in the exchange, in individuals getting subsidies, it definitely affects the people that are getting subsidies, but they're getting a large amount of that subsidy paid for, so it's not hurting them as much. The individuals that are really getting hurt with these large increases are those that are above 400% of federal poverty level, and when these increases are passed on, it's hitting their pocket fully because they're not getting a reduction in their premiums in the form of a subsidy. So talking about the rate filings for CMS that were due August 16th. They were given 3 more weeks to finalize, so it's actually pushed the deadline to September 5th. For all the different states that are using the federal exchange through healthcare.gov, which Georgia is part of, they have until September 27th to sign an annual contract, and that would lock everything in for the 2018 year. So we could see some things change between now and then. But as far as the update and where things stand today, there are 5 health insurance companies currently selling on the exchange in Georgia as it stands right now. Now in different pockets of Georgia, but Humana is the only carrier that's exiting the individual. So we're talking about individual here, exiting the individual exchange in 2018. Really won't have a bearing on many of you in the room today because Humana was really only selling in the Atlanta, Columbus, Macon, and Savannah area for 2017. So this is not going to really affect those of you in North Georgia, but we will be going down to 4 carriers. And I also want to note, in case you saw it in the paper, again, or online, Blue Cross Blue Shield early on was saying that they were going to back out of the market completely in Georgia for individual. After discussions with the Department of Insurance here in Georgia, they elected to stay in the exchange, but they're only going to participate in the counties that otherwise would have not had an insurance company. That happens to be 85 counties, but it's mainly in rural, South Georgia, and that they will be exiting the market, and we'll talk about that for the North Georgia market. An interesting stat as far as enrollment numbers go, enrollment in Georgia dropped by 16% in 2017. And the national average was 5% there. So a drop off, you had people that maybe were going to group plans, people that were going without or purchasing short-term, gap type policies in lieu of having an exchange policy due to the pricing. And here are the 4 carriers that are going to be selling on the individual exchange in Georgia for 2018: Alliant, Ambetter, Blue Cross Blue Shield, and Kaiser. So of the 159 counties in Georgia, only 14 of the counties are going to have more than 1 insurance company for the individual market. And those 14 are mainly in the metro Atlanta area. Hall County and many of you in North Georgia will have 1 option, and that is Alliant Health Plans. Want to make sure to let you know there, though, the good news there is that this year we had Alliant and Blue Cross Blue Shield. A lot of people signed up for Blue Cross Blue Shield to find out that it's an HMO product and it was not in network at the hospital. The good news about the Alliant plan is that it is in network with the Health Partners Network, which is a strong local network here, as well as getting access to Alliance Network, and should not have a problem finding a provider in network in the North Georgia area. So that's good news there. As we talk about rate filings here in just a little while, one thing I want to note is that the insurance companies are filing two separate rates. So they're filing a rate in hopes that the cost sharing reduction stays in place, and then they're filing a rate in case it goes away. And as I mentioned earlier, if it does go away, it could be 20 to 25% more in individual costs for those that are on the exchange and buying individual plans. Here's a map of part of North Georgia, and I want to talk about what counties are going to have the participants, what insurance company is going to be in each county. So those that are in a green A there include Dawson, Lumpkin, Union, White County, Hall County, Habersham, Banks, Franklin, and Stevens. Also some of the other surrounding counties include Dammann, Gilmer, Hart, Pickens, Raven, and Towns County. Those North Georgia counties are going to have Alliant as the in-network only individual carrier to purchase individual policies in 2018. As you see down there in the kind of the bottom right, Jackson and Barrow County, and that also will extend into Oconee and Clark County, in there with the purple A. Those are only going to have Ambetter in their counties as the only individual company option there for 2018. And then for Scythe, Gwinnett, listed there with an A and a K. The A is Ambetter, the K is Kaiser. So they are two of the 14 counties that will have two individual providers to choose from. That also will be the case for Cobb, DeKalb, and Fulton counties. We'll have a couple options, but again, very limited in regards to the selection that you're going to have to choose from. As I mentioned, open enrollment is only 45 days this year. An individual's really not going to have a choice to make. They're going to have a carrier, and it's going to be really what plan that they're going to pick within that product portfolio. So the individual and small group rate filings for 2018, I know that there are some carriers in the room, so I need to preface this before I get in trouble. The rates are filed each year for the upcoming year, and they are filed online, so it's public, you can view it, but they are never finalized until the very end. So we're going to talk about some average increases, and this is across their block of business. You very well could be below that or above that based on your policy or where you're located. But this just kind of give you an average increase and really laying the stage here to show you how much the individual increases are going up compared to small group, because that is very important. So we'll jump right into things with Aetna in the small group market. They're, again, not in the individual, so this is specifically to small group with an average increase in their HMO. So we're going to talk about HMO and point of service because most of these companies are going to have plan portfolios in both networks. Their average rate increase is 17.5% on HMO and 11.81% on point of service plans. We've not seen them as competitive in the small group market. I know that they're targeting really level funded plans, where you can be medically underwritten, and so that'll be something that they continue to look at. Alliant, as we talked about, will be the provider for North Georgia for many of you in the individual market. An average increase of 18.6% in the individual market, and then at this time showing some possible decreases in the small group market. And they really had not been competitive in small group for new business as competitive as they've been in years past this last year. So this should put them in a more competitive place for 2018. I did want to note on the network difference for Alliant on individual versus small group. So with the individual market, as I mentioned, you have access to Health Partners Network, strong local network, but you do not have a wrap network with that plan. So there's not a national network that wraps that plan. In the small group market, though, they will allow you to purchase a wrap network, which is a PPO network that will give you nationwide coverage across the United States. And that is the ability, if you want to pay a little bit more in the small group, to have that wrap network. But again, it's not available in the individual. And then Ambetter, again, selling in the individual market, average rate increase about 12.4%. And it's not available in Hall County, as I mentioned, but is available in Forsyth, which is close with Gwinnett as well. So Blue Cross Blue Shield, we've broken this up into two different categories. The first being the individual. Some steep increases here, as you can see, close to 39% on the HMO product and 44% on point of service. This is really going to be, it's not going to affect most of you in this room because, as I mentioned, they're really only playing in the counties that wouldn't have had a participant, and a lot of that is in South Georgia, but there's going to be large increases passed along. Those people that are getting subsidies are going to have most of that, picked up. But for those individuals that are above 400% of federal poverty level in the counties that Blue Cross will be selling these individual policies, it's going to be a financial burden, for them. In the small group market for Blue Cross Blue Shield, 7.68% on the HMO product, 9.8% on the point of service. Again, depends on where you're located, but the small group selection for 2017 and looking at the plan portfolio of what Blue Cross is going to roll out for 2018, very similar, to that of what they're offering in 2017. They are going to offer a few additional plans in 2018. And for those of you that are familiar with the Humana Simplicity plans, they're very popular. Blue Cross Blue Shield is going to come out with their version of those for 2018, so they're going to look to try to be competitive in that market. Humana, small group, really has been very competitive in North Georgia in the small group market, just under 12% for both HMO and point of service, which will keep them very competitive. For those of you that are with them or have looked at them, you know that they have their wellness, and it fits very well that they'll be talking on wellness today. Have a wellness program, Go 365. If you have an employee that meets silver status as part of participating in that program, you can get 7% off of your rates. And if they meet gold or platinum, you can get 15% off your rates. So, those of you that do have Humana, very much encourage you to participate in those programs. There's some things that you can control on cost, and that is one of them, and that'd be a way to keep the costs down for you and your organization. Kaiser in the individual market, 25% individual average increase and just under 7% for the small group. Again, good for you to know, but there's really not a Kaiser location that's in North Georgia, so for most of you in the room, this will not affect you. And then United Healthcare, they have a number of different network options, and that's what the Heritage Plus, Choice Plus, and Choice are, but all under 10%, which will keep United Healthcare pretty competitive in the small group market for 2018. So you'll know that of the companies that David mentioned earlier, Cigna was one of those. It's not listed on here. It's because they are not in the community rated space. In the small group, they're medically underwritten, so they're not going to have a rate filing for that. And then those of you that are in the 50 to 99 segment, you know that you're getting medically underwritten. Some of your rates based off of you, and then of course the insurance company and their block of business. And then as you get into the larger group and 100 plus, your experience rated as well as blended with the product, from the company. So, this is really focused on small group and individual as far as what these trend increases or what these increases are looking like for 2018. Again, we're going to have this finalized in the next month and in time for rolling out the plans to the consumers for 11/1 of 2018. We talked about this last year, but we still get oftentimes questions asked about it. Are we seeing small employers eliminate their group health plans and go into individual plans? And if anything, we're seeing the opposite. We're having more people that have maybe gone to individual market in the past years that are trying to find ways to get back in the small group market. As we looked at with the rates, the individual rate increases are outpacing the group rates. And so you're going to continue to see that trend happen. And, it's one of those things where when you look at the pros and cons of having an individual or group, we have seen some very small groups that maybe their employees were going to get a subsidy, and so they figured the employee could go and get a subsidy instead of them funding it for them. But because of the limited options, the number of plans, the number of carriers, as they dwindle down, and really it's not seen as a true benefit to the employee. You try to hire someone in January of this year, and they're without coverage, they don't have a qualifying event, then you didn't have a group plan, then they're going to have to wait until 2019 to get coverage. So it's not really seen as a recruitment tool. So we are seeing small groups that have gone individual going back towards small groups. As far as husband and wife groups, I know this is something that comes up often. Many of the carriers have gotten away from writing a husband and wife, small group. Alliant is one of the small group carriers that will still write a husband and wife group if they're both on the wage and tax form. So if you have a mom and pop type business that's just maybe husband and wife run that had to go to individual due to their carrier, no longer offering those type of plans, Alliant could be a fit for you. So that's something to consider. We have had some increases in the HSA contribution amounts and the out-of-pocket limits for 2018. For an individual, you can contribute $3,450 for your HSA, $6,900 for a family. Remember that if you're over 55, you also have the ability to have the $1,000 catch-up contribution there. For an HSA, max out-of-pocket, it's increased as well to $6,650 for an individual and $13,300 for a family. And then just your non-HSA, maybe your copay plan, the out-of-pocket maximum is $7,350 for 2018, and double that to $14,700 for a family. So keep that in mind. And really, the carriers are going to be offering plans that are going to be, that are going to meet those needs. But if you're self-funded and trying to look at what you can take your numbers to, that's something important to keep in mind. As we talked about, the ACA is still the law of the land at this point, and the mandate penalties still apply. So just as a reminder of what they are, the penalties are assessed, typically in 2018 for the 2017 year based on what you have. We really don't see many employers at the 50-plus market, so this is groups that are required to offer coverage. You either have more than 50 full-time employees or full-time equivalents. And we're really not seeing many people just say, we're not going to have a health insurance plan. We're just going to pay the penalty. But if you did elect to do that, then the penalty is $2,260. And I'll give you an example of that. Let's say you have 100 employees. You can minus the first 30 employees, leaves you with 70. You multiply that by the $2,260 number, and that gets you a penalty of $158,200. Non-tax deductible. You're going to pay that penalty for not offering coverage. Now, we do see more people in the second penalty that it could apply to them. So this is the failure to offer affordable coverage, or it doesn't meet the minimum essential requirements. So maybe you have a group that has an MVP plan, a MET plan, MEC, it comes by a lot of different names, a skinny plan that it does meet the individual mandate, so it's satisfying that for the employee. Typically, the cost is in range, so it is affordable, but maybe the plan has office visit copays and prescriptions, but it doesn't have hospitalization coverage. So therefore, it does not meet the minimum essential coverage for having that benefit. In that case, you would open yourself up to a penalty if that individual went and purchased a plan on the exchange. That penalty is $3,390 per employee. It's prorated over 12 months. So, if you were, it'd be a fourth of that penalty if you did have, 3 months out of the year that you had somebody on your staff. We really see these plans in markets where, there's high turnover, or where the individual is satisfied with having a plan that has office visits and prescriptions, and willing to run the risk of not having to pay more, but not going to have hospitalization coverage. So keep those penalties in mind. Also have a couple changes in place for the safe harbor for 2018. So just to kind of give you an idea before we jump into the numbers, employers, many of you don't know the household income of your employee. If they have family members, so or you shouldn't necessarily know. So in lieu of household income, you're allowed to have the employee's W-2 wages from box 1, the employee's rate of pay times 130 hours, or the individual federal poverty level. Those are some of the things that you can view. And as you remember, in 2015, what was considered affordable was if it was 9.56%, no more than that of the individual's income. That's gradually increased to 9.66%, to 9.69, but now for 2018, it will be going down to 9.56, back to the number from 2015. Most of you are probably with payroll carriers that when they're running the systems, they're going to see if something's out of compliance and say, what you're charging based on this employee's pay is not going to, it would open yourself up to the possibility of that $3,390 penalty for not being affordable. But just as a second, one of those things just to kind of, really monitor what they're doing and to double check it. This is something to keep in mind and make sure that you're staying within that percentage on what's affordable to the employee and what's being passed along. Talk about Medicare, but before we get into there, we'll talk about a question that we get often, and for many of you in the room, this might be common sense, but believe it or not, we get it more than, and I think people know the answer to it, they just want to ask it in hopes that we're going to give them a different answer. But, can we identify a high-cost claimant and encourage them to move on to the exchange, or, if they're, over 65, say you need to go get on Medicare. So, this violates all types of things, including ERISA, HIPAA. So stay away from doing that. That can be one of the things I'm sure the compliance panel would really advise you not to do that. So, but keep that in mind that's there are those plans that are out there, but you're not able to incentivize to push someone there. Just as a recap on Medicare, If you have less than 20 employees, then Medicare is primary. If you have more than 20 employees, then the group plan is primary. A couple other things to add there, 3 others to note, that if you do have an individual that has a retiree plan, maybe you have a retiree plan as part of your population, then the Medicare is always primary, your retiree plan is secondary. So that's one thing to note. COBRA always pays second to Medicare. So if you have someone that goes out on Medicare. And then from a disability, if you have someone on Medicare disability, Medicare is primary if the company has less than 100 employees, and it's secondary if the company has more than 100 employees. So I know that's a lot of different numbers there. If you have that come up and you have any questions, feel free to reach out to us, and we'll be happy to give you kind of an idea on where you fall in that population. I'll leave you with this. As a reminder, the Medicare Part D notices are due by October 14th of 2017. Medicare Part D imposes disclosure requirements on groups that provide a health insurance plan that has prescription drug coverage to Medicare eligible individuals. So you need to make sure to get that out. And I look forward to answering any questions following the seminar. We'll stick around, and thank you again.
All right, well, the panel is coming up. One thing I did want to mention is that we are actually taping this. So once we edit it and put their names in the appropriate boxes, et cetera, we will be putting it on Brenau's YouTube channel, and we'll forward a copy of the hyperlink to the chamber. So check the chamber's website, you can check Brenau's YouTube channel, probably in the next 3 to 4 weeks, and we'll have the symposium online. You can look at it again. And, I think Brett said that there was a lot of good information and also a lot of numbers that he was talking about. So you can go back and check those. You can also call Brett or someone over at Turner Wood & Smith to give you the latest information on where things stand. All right, as he outlined, despite unprecedented levels of anticipated change and disruption, whether you like it or not, the ACA remains the law of the land, making it necessary for employers of all sizes to focus on compliance. Many employers have spent the last 2 years preparing for and navigating the new ACA reporting, disclosure, and notification requirements. We're fortunate today to have representatives from the U.S. Department of Labor, our favorite benefits attorney, and the compliance director from Turner Wood & Smith Insurance Group. Now is the perfect time for you to determine if you are ready for a potential Department of Labor audit. So let me introduce Rob Fowler and the panel.
All right, good morning. Another great crowd. This is awesome. I want to add my thank you for attending the seminar this year. This being the 6th annual seminar. How many of you have been to all 6 of them? Raise a hand. Oh my gosh, that's so good. So thank you for doing that. I see Jeff Gill from the Times down here. He's been there, one of them. And he does a great job of covering it, and Access WDN. We appreciate the coverage of the media because that helps us in educating the citizens of what's happening, especially with a lot of things that Brett was talking about. So can you believe 7 years ago, over 7 years ago, ACA was passed, okay? And so, everything had to be in place by September of 2012. And so that brought on tremendous change for employers. Brought on tremendous change for our agency. And there are a lot of insurance agencies that just chose not to compete in this complex environment. They weren't going to do that. So we've seen a lot of independent agencies sell out. And but I want you to know that since 2012, we have doubled our staff and our resources to support you, our clients. And for our clients that are here today, I wanted to thank you for your loyalty and support, because it's been a tough time. These last few years have been tough on everyone, and we hope that we've been able to support you. 3 years ago, we joined the Benefit Advisors Network. We were asked to join what they call BAN, BAN is made up of 70 independent agencies around the country, the top 70 agencies, some of the best in the country. What that allows us to do is be able to provide resources without having to bring them in-house, but we share those resources, and we have actuarial staff and human resource staff and wellness and legal and compliance. And so I tell you that because now our agency can compete with any agency in the state, and I feel like in the Southeast. And I think it's important for you to know, I mean, you're looking to your insurance broker consultant to be able to be there to do the hand-holding for you. And I'll give you an example of that. We recently competed in an RFP process on a 1,400 employee account. There were 12 agencies that competed, 4 finalists, which we were one of. The other 3 agencies were some of the largest agencies in Atlanta, and I'm proud to say that we secured that account. So we did that because we showed a commitment locally and with the resources we have locally and nationally to be able to compete and deliver what the client needed. So I'm proud to say that we're locally owned. We have 39 employees who call Northeast Georgia home, and hopefully this time next year you'll be able to see us in our new building in front of the Francis Meadow Center off Jesse Jewell Parkway. So that's my end of my commercial. You know, we talk about compliance every year, but not to the extent we are this year. You know, and why are we doing that? You know, if you think about it, you know, Brett, I kind of look at it as kind of like the balanced meal. You know, this will tie in with Dr. Montgomery's remarks. You think about it, Brett kind of gave you the meat today. And this compliance, what we're going to be doing compliance today is kind of, well, if you think of it, is like the vegetables. You know, everybody doesn't like to eat their vegetables. But you know you're supposed to, so that, you know, you have a balanced diet and you're healthy and that sort of thing. But we sometimes don't like to eat our vegetables. So, and then we'll just say, Dr. Montgomery's coming up, he's the dessert. Well, he's talking about wellness, so he's the fruit. I don't know. All right, so why are we devoting time to this? When you think about the client-broker relationship that I was just talking about and how important that is, this was from a Society of Human Resource Management survey. Top 3 employee benefit broker services you, as employers, attribute as most important. So 84% provides updates and guidance on healthcare reform and other legislative services. Answers your compliance-related questions, 84%. And provides compliant plan documents, 78%. These are the top 3. So we felt like it was very important that we spend some time on this, and that's why we're doing it. We also polled the Greater Hall Chamber of Commerce Human Resource Council, which some of you may be on, and they have a great organization, and they identify compliance as one of their top concerns. Additional SHRM survey data says that these are the general audit concerns for employers. So the focus being on audit. So when you think about plan documents and summary plan descriptions and COBRA and HIPAA, all of these kind of things, these are all things that come to mind, and you may have others. In your packet, I think it's on the right side, right behind your agenda, you should have 3 documents, 3 handouts. One of them is the DOL audit notice request list. The next one's a benefit notice timeline. And then you have the 5 most common DOL audit mistakes. I really urge you to keep these in front of you as we do the panel today. And so and then make sure that you take these home. This is the vegetables right here. This is where it really happens. And I could have flooded your handout, you know, giving you a ton of handouts, but I think these 3 documents are 3 of the most important documents you'll take away from today. I will tell you that these documents have been reviewed and approved by our ERISA attorneys, so they are good to go. I know Wendy's looking at them right now going. So don't say anything, Wendy, until after the program. Let's look at our panel. Okay, so in your agenda you saw that our panel members, Ann Tyler Hall from Hall Benefits Laws back for her second year, and thank you, Ann Tyler, for coming back. Wendy Southern joined us for the first time, and she's a senior investigator with the U.S. Department of Labor, Employee Benefit Security Administration. She was telling me, you'll see their bios behind the agenda, so I'm not going to take the time to go through those, but she told me that she also prior to the DOL, she worked with IRS. And I told her she's probably one of the most popular people at the family reunion, you know. So she's so nice, and I think you're going to enjoy hearing from her. And then Anna Hewell, and Anna joined us a year ago as our compliance director and large group analyst, and that's part of those resources that we added. We do have a dedicated compliance director, which is rare in insurance agencies today. So here's how we're going to operate today. I'm going to allow, I'm not allowing, but they are going to allow themselves they're going to take 6 to 8 minutes to do an introduction, and then we'll do the questions from the panel and then questions from you in the audience. So those questions from you, if you could do this, just kind of follow the outline here. If you have a question that you'd like the compliance panel to ask, will you just put on a piece of paper your name and email address. If you have a particular panel member you want to answer it, put that down. But this is important because if we don't get to your question, I want to be able to get that answer to you. So that panel, the questions will be given to the panel members, and they'll email you after the session. All right? Everybody ready to go? Compliance. And Tyler, come on up.
It is great to be back this year and talk about an issue that is near and dear to my heart, ERISA legal compliance. I'm an ERISA attorney, and day in and day out, we are helping clients really in 3 different areas. They're already in a Department of Labor or an IRS audit. HHS has come in and evaluated HIPAA compliance and found an issue. Generally, we're working with 3 different governmental agencies: Health and Human Services, the Internal Revenue Service, the Department of Labor. We're also seeing more involvement from participants. Participants are becoming more savvy as to their rights, and their plaintiffs' attorneys are becoming savvy to those rights. So we had, for example, a client that called us and got a love letter from a plaintiff's attorney on a COBRA notice that was failed to be delivered to the participant. And there are ensuing penalties and from the Department of Labor and the IRS, and so we're seeing plaintiffs' attorneys, participants become more savvy to their rights, and that's also an area of exposure. But a little bit about our firm, Hall Benefits Law. We work with employers on their employee stock ownership plans, ESOPs. We're seeing this become more and more popular as we see baby boomers retiring and not necessarily passing along the business to their son or daughter or to a family member, but actually selling the company to the employees. So we work in ESOPs. We also come across benefits issues in mergers and acquisitions. Example, a client out in California acquired a company. They had a legacy employee that was on long-term disability, called us and said, what do we do? This is going to be a $250,000 liability for us if we did this incorrectly. And thankfully, we were able to address this situation and mitigate the plan sponsor's exposure. What we advise our plan sponsor clients to do is if you're thinking about a merger, an acquisition, being sold, that you look at your benefits programs and how they're going to merge and how they're going to interact with your buyer or your seller's plans before the transaction occurs, not after. As I alluded to earlier, we came in after the fact, after a transaction had occurred, and it was potentially going to be a $250,000 liability. But I think that highlights why it's so important to be proactive and preventive with respect to ERISA legal compliance. And Rob mentioned it earlier, like eating your vegetables, but it's so important because we see it on the other side. We're happy to help our plan sponsor clients that are already in an audit. We've got a client that was assessed a $30,000 penalty from the Department of Labor. Happy to help clients when they're in that penalty situation. We prefer to help our clients avoid those types of situations. We also help our clients with executive compensation and looking at plan design and ways to attract and retain top employees. And so we work on a host of executive compensation programs, supplemental executive retirement plans, and we enjoy working with our plan sponsor clients to design those programs. Health and welfare benefits, which is what we're going to talk about today. Healthcare reform, which is changing potentially, and so staying abreast of those changes as they come down the pipeline. And then retirement plans, right now helping actually a mid-sized law firm look at their individually designed retirement plan and think about, is this has the law firm optimized plan design so that they get maximum participation, that the employees, the participants feel like they're benefiting from this retirement plan and maximizing the tax advantages to a qualified retirement plan. So that's a little bit about Hall benefits law. Our focus is experience. My background started at Alston & Bird, King & Spalding. Leah Singleton just joined us from Alston & Bird. So we got that large law firm background, but we love being on this platform where we get to partner with our clients and really think about how to best offer benefits and avoid costly legal non-compliance issues. Responsiveness, we love our clients. We love our plan sponsor employer clients, and we want to help them get to the best result possible on their benefit program. Efficiency, and then as I alluded to earlier, our goal is to, we'll talk about this a little later, but Department of Labor alone assessed $777 million in recoveries last year. Penalties, excise taxes, fines. We want our plan sponsor clients out of that $750 or $1 billion pool. We want our clients staying out of those penalty situations. So our focus is on proactive, preventive mitigation of legal compliance exposure. And so as part of that, we counsel on proper reporting and disclosure notices, review of health plan, administrative services agreement. These are some of the activities, some of the projects that we're currently working on to try to make sure that, again, our plan sponsor clients aren't in a penalty situation or participants upset filed a claim against the employer. Counsel on cost-efficient health plan design alternatives. That's a big focus of our practice. And again, just addressing legal compliance issues before they become costly legal non-compliance errors. This is, we would love for you to follow us on Twitter, Facebook. We also do a monthly HR alert on recent developments. The IRS, the Department of Labor, HHS, they are active, they're busy, constantly releasing updates and new requirements through the regulations, and we stay on top of those and write about them. So we would love for you to sign up for our HR alert. Thanks so much.
I did want to make an announcement that Shelly Davis is going to be, there she is. She's going to be walking up and down the aisles collecting any questions. So if you pass those to the right side, she'll collect those throughout the morning. Thank you.
Good morning. My name is Wendy Southern, and I'm a senior investigator with the U.S. Department of Labor Employee Benefit Security Administration. I want to tell you a little bit about our agency and kind of what to expect in a health plan investigation. Firstly, let me tell you that our agency is on a small scale. We have approximately 800 to 900 investigators across the United States. So we have a small agency with large responsibilities. My focus as of the last year or two has been primarily on service providers, that being insurers, third-party administrators to health plans. And the reason for the focus on the service providers would be intend for global correction, so we can find a problem, fix it at the source, and hopefully avoid any more of these compliance type errors. So the mission of the Employee Benefits and Security Administration is to assure the security and retirement of health and other workplace-related benefits such as long and short-term disability of American workers and their families. We accomplish this mission by developing effective regulations, assisting and educating workers, plan sponsors, fiduciaries, and service providers. We provide webinars, generally a couple of times a year. That information is available on our website at www.dol.gov/agencies/EBSA. Those tools are out there and available for anyone at any time, and they have many FAQs, frequently asked questions, that can be assistance in any decisions that you're looking to make toward your plan. Additionally, in EBSA, we enforce the law vigorously to protect these participants and beneficiaries that are enrolled in these plans. We have two divisions. We have the enforcement division, and then we also have a customer service division that seeks to educate. They do a lot of outreach. They're available for your questions. They take anonymous questions, or I have a friend type questions, or whatever the case may be. And they are available with a toll-free number that I can provide to you. Actually, I do have it with me, but it is 1-866-444-3272, and that gets you to a benefit advisor. And if there is an issue that needs further development, the benefit advisors will forward it on for review for investigation. Our EBSA's organizational chart works with, we have the Secretary of Labor, who is our Alexander Acosta, just recently appointed. And right now we have some current openings in the Assistant Secretary. We do have Tim Hauser as our Deputy Assistant Secretary. And then we have many different offices that fall below that. So the ones that primarily affect health plans would be the Office of Health Plan Standards and Compliance out of DC, and the Office of Exemption Determinations and Enforcement. So, and those all run out of DC, and those filter the regulations down to us being the regional offices. There are 10 regional offices, and of course I'm out of the Atlanta office, which covers 7 states. So that would be Mississippi, Alabama, Georgia, Florida, North and South Carolina, and Tennessee. We also have 3 district offices for the larger regions that need a little more assistance. So we have a field office in Miami as well that's also within the Atlanta regional office. So EBSA's structure we follow as a regional office, we follow national office mandates. National office establishes policy and agenda protocols. They have oversight of reporting and disclosure requirements. They draft the regulations and provide interpretive guidance. We have a special division for that. It's ORI, which is our Office of Regulatory Interpretations. They conduct economic research to determine the impact of policy and regulations on the community. And they also do outreach programs such as the health benefits education campaign. As a regional office, we conduct the actual investigations of ERISA plans. We provide compliance assistance through benefit advisors. And that was the number I was telling you to call in, and they'll be happy to discuss with you any issues, help you solve a problem. If you're a fiduciary and you have a question about whether it would be a particular thing would be in compliance, they'll be able to provide you with that information or direct you to someone who can. We are very hands-on in regard to our plans and providing you education. We conduct outreach to plan sponsors and other stakeholders. So generally, there are outreach meetings around the area within the region a couple times a month. So we have some of our benefit advisors that go out and do a specific slideshow presentation and to different groups. And then we also have programs that just go in and discuss alternatives or what's next with maybe companies that are going out of business, changes, mergers, and so forth. So in regard to just some basics for the group health plans, the Employee Retirement Income Security Act of 1974, which is ERISA, applies to only employee benefit plans that are sponsored by private sector employers and or unions. So no governmental plans like your state government, local government, they're not included. No church plans, they have some different regulations. And there may be some other exclusions that apply. But generally, ERISA allows plan sponsors to decide whether to offer a plan and allows the flexibility in the plan design. However, keep in mind that there are mandatory regulations that must be met within a group health plan. A few basic things a group health plan must have is governing documents, and they must comply with ERISA. So when I come in and look at the records for a company, I start with the adoption agreement. I want to see, where the plan started out, what decisions were made in the setup of it. Then I look to the plan document, and in this case, it would be a certificate of coverage or a benefits booklet, also to the schedule of benefits. I also look for a summary plan description, and a lot of plans think that just providing a certificate of coverage qualifies for a summary plan description, but that is not the case. There are specific items that need to be listed in a summary plan description, such as who to contact, who is available for legal service, what the address is, who the trustee or the fiduciary is. And so an SPD is important outside of just the certificate of coverage. You must have a named fiduciary for plans, and you must have reasonable claims and appeals procedures explained where we can follow the process, where your participants have the knowledge of how to appeal a claim, what steps to take, what their second appeal process may be, and any, the response to adverse benefit determinations. Additionally, fidelity bonds are required to protect against dishonesty, and unless the plan is solely funded by general assets of the plan sponsor, the plans must have a fidelity bond. Regulation of the group health plans. ERISA regulation, we enforce Title I of ERISA. It applies to employee welfare benefit plans. And we review other laws that are also reviewed in regard to group health plans include the Americans with Disability Act, Pregnancy Discrimination Act, Fair Labor Standards Act. Now that's also handled within the DOL, but it's handled within wage and hour. Public Health Service Act, that's HHS, and then the Internal Revenue Service Code. So the Department of Labor, the Internal Revenue Service, and HHS work together in regard to the regulations for health plans. Health laws that are included in ERISA Part 7 are COBRA, the Consolidated Omnibus Budget Reconciliation Act, and that's coverage that is offered once employment has been terminated with the company. The Health Insurance Portability and Accountability Act, HIPAA, protecting our private information, a Mental Health Parity Act, Newborns and Mothers Health Protection Act, to ensure that women who have just delivered babies have sufficient care in the hospital that is directed by their physician and not by insurance. Genetic Information Non-Discrimination Act, Mental Health Parity and Addiction Equity Act, that's MAPIA as we refer to it, and CHIPRA, which is the Children's Health Insurance Program Reauthorization Act. And CHIPRA can offer some assistance in premium payments for children's health care coverage. Most states offer some aid through Medicaid, and there are documents available that you provide to your employees that list these states and contact information. Those should be included upon hire in the enrollment. Michelle's Law is also under our jurisdiction, and then, of course, the PPACA, the Patient Protection and Affordable Care Act. Department of Labor's enforcement rule is DOL is responsible for enforcing the requirements of Title I of ERISA, which with respect to the employment-based group health plans. So that's all I have for now, but I appreciate your time.
So in the 2016 Broker Services Survey, Rob kind of hit upon this a little bit earlier. They asked the companies to select their top employee benefit challenges. And from those responses, we most certainly would expect that managing healthcare cost was the #1 reason. But #2 was keeping in compliance and up to date on changing regulation. There were 2 additional challenges that were noted that also involve compliance with the Affordable Care Act. So as Wendy just discussed, the Department of Labor they administered the provisions of the Title I ERISA, which was enacted in 1974. And that continues to be amended, as she highlighted a lot of those laws that kind of fall under ERISA. But with the passing of the ACA, there was a kind of a shifted approach within the regulatory agencies that kind of fed off the ACA compliance enforcement position. And while there might have been a additional flexibility in the past for a more reactionary approach, employers now need to be more proactive in pursuing compliance. To kind of stay ahead of that curve, Turner Wood & Smith proactively pursued additional resources to drive a bigger focus on compliance and to better assist and support our clients. So at TWS, the model is a client-centric model. TWS at its core is, we understand that employee benefit consulting is about you and not us, and we continue that philosophy within our compliance support. Our focus is to understand your needs. So we have multiple communication avenues that we do to keep you up to date. We have also invested in several different programs to kind of arm you with hands-on tools and resources. And we also have additional resources at our fingertips to address a variety of other compliance needs. One of the first steps that we encourage is allowing us to kind of come out and do an initial evaluation or a discussion with you. This kind of allows us to discuss and highlight some of the primary areas of compliance, as well as answer any questions, discuss any immediate needs or concerns, as well as kind of identify any possible gaps and the option of addressing them with the appropriate resources. with our hands-on approach, we are, will guide you and hold your hand as little or as much as you want throughout the process. So one of the tools that we did invest in was HR 360. This is one of the biggest features that I think about this is the HR library. This features attorney review tools, guidelines, and forms that can kind of to help make things a little easier and serve as a resource. The Smart Compliance Portal is another great tool. It has various education tools, checklists, and reminders to keep you on top and proactive with compliance. One of the greatest things that I think is about this is the My Vault feature, which is a cloud-based document storage for DOL audit-ready files. One of the things that I really highlight and focus on and stress is that keeping everything in one place so that if you are kind of selected for a DOL audit or someone's coming in, that you have all that information ready. And whether that's in an electronically based or if it's a paper-based or hard copy-based, to have all that information together. And this is one way to kind of help you do that. So a lot of times the response we get when we ask an employer about compliance is, oh, well, my broker handles that. But and while you may surround yourself with best attorneys, accountants, consultants, ultimately you are the plan fiduciary and the one held responsible for your plan. Plan fiduciary is a person or entity named in the written plan or through a process described in the plan as having control over the plan's operation. Now, when acting solely within their professional capacity, attorneys, brokers, insurance agents, consultants, they are not the plan fiduciary. So just keep in mind that, as we see, compliance continues to, is one of the top challenges for employers. And you need for employers to continue to be proactive in the pursuit of compliance. Compliance support is essential. And at Turner Wood & Smith, our focus is on proactive employee benefit plan compliance.
All right, thank you, Anna. All right, we'll have the panel come up. Again, if you have any questions, please pass them to the right side of the aisle. We've gotten a couple so far. All right, let's see, ladies. All right, we'll jump right in now. Some of these questions I'm going to ask specifically of a panel member. Some of them I may throw out, but ladies, don't feel like you have to, everybody have to comment, okay? Because we probably have a lot of questions to go through, and I want to, move this along. So, all right, first question. In prioritizing an employer's approach to compliance, what would you recommend focusing on first? So I'll throw that out to the entire panel, these first couple of questions. And you pass the microphone.
Yeah, it's interesting because, and again, we work with clients and plan sponsors who are in transition or doing transactional deals. It is fairly astounding how common it is for plan sponsors to not have the basic plan documents. And I think that is and I'll let Wendy speak to this, but I saw it on one of her slides, that is an audit target area. We're working with 2 plan sponsors right now that have been filing one Form 5500 for their health and welfare benefits. And you can probably guess what they need for that. They need a wrap plan document to be able to file one Form 5500. They don't have it. They don't know where sometimes it's the HR professional has left and not left a great paper trail. Sometimes there's just a lack of awareness about what documents are needed in the health and welfare benefits arena, but I think that's a basic, is making sure that you have all of your health and welfare benefits documents in a file. I recommend electronically, hard copy, and that's the first step. The next step is making sure that on your Form 5500 you are diligent with respect to what you're reporting, and that there are no red flags that would be easy for the Department of Labor to pick up. And again, I'm interested to hear what Wendy has to say about this, but we had a former auditor in our office a few days ago, and she said, I was tasked with going online and looking at the Form 5500s for plan sponsors and picking out red flags, and that's who we'd audit.
And we do review Form 5500 regularly for compliance. We review just particularly some of the smaller areas that you don't really pay attention to, but there are little check boxes at the end. And we review those answers and look for any errors in that. That is a big, as you say, a red flag for us in regard to choosing our investigations. Additionally, we look at the plan documents, and ensuring that you have an SPD, a summary plan description, is very important. And I see it so much in regard to group health plans that they do now have this document. They have encompassed some of the information that should be included within either the certificate of insurance or within other various documents. Additionally, I need to see contracts with your service providers. I look to review those. I look at what diligence you performed in regard to choosing those service providers. So those are all some of our questions when we come in, what we start and review with. There is a great list included in this packet that gives you some of the documents that are requested in a DOL audit. And they're just the beginning. They can go on further. Once we get in and review, we may request further information. So I got my little off topic, sorry about that.
I'm just interested, Wendy, what are some of the SPD deficiencies that you come across?
Well, we may not have the information for the employees that would give them a contact person. Or if there is a problem that they cannot resolve with their company, it may not direct them to the Employee Benefits Security Administration, which is required, that information is included. So we have to have the information to make the participant knowledgeable as to what their rights are.
Okay, good. Why don't we do this? If you will, in your handouts, you remember that one document, the 5 most common DOL audit mistakes. If you look at the back page of that, it addresses mistake number 1. It addresses exactly what Ann Tyler and Wendy were just covering. No summary plan description or plan document. So you can read that. I'm not going to take the time to go through that now, but Dave Johnson, thank you for your question. And Wendy, Dave's asking, how do you determine if an SPD is written to be understandable by the average plan participant?
Well,
Steve's microphone.
in regard to whether it's average plan, so we look at is what is understandable, what is plain writing, what directions is a normal participant going to be able to pick up the document and follow it? Is it going to give them substantial direction to answer their questions, to get copies of plain documents that they needed, to get copies or to request additional information? It should direct them to the person they need to request from, and then it also should provide them with information in regard to the plan. What types of coverage are offered, if there are multiple types, and the direction of each of these plans as well.
Okay, thank you. One of the things that comes up, and it can be confusing, and I'll throw this out to the panel, but we talk about SPDs, we talk about plan documents, and then you hear the term wrap SPDs and wrap plan documents. Could y'all tackle that and help explain what the differences are?
Yeah, so a wrap plan document, it really is intuitive. It wraps around your health and welfare benefits. And therein, in your wrap plan document, should be all of your ERISA legal requirements, basically all of your notices, your Newborn Health Protection Act, Women Health Cancer Act, all the Affordable Care Act notices. We regularly draft these to ensure that you've got one document that you could hand to the Department of Labor auditor that says, we've got all of our ERISA legal compliance disclosures and notices in this document. Now, I say that loosely, not all, there are other documents that you'll need in addition to a wrap document, certificate of coverage, and typically what we'll do is we'll append those documents to the wrap document. But the wrap document is great because it wraps around your health and welfare benefits. You can file one 5500, Form 5500 generally instead of 5 or 6 for each different health and welfare benefit plan. So it's a great tool for centralizing your ERISA legal requirements and having those in one document, and then having one central document that you can go to and provide to participants that fulfills many of your ERISA legal compliance requirements. And I would just add to the prior question around in plain language in an SPD, we as a firm look at it as the VRF, benefits, rights, and features. And that needs to be clearly disclosed in your summary plan description. We've come across problems with the SPD plain language a little bit more on the retirement side, actually, when we've come across pension plans with complex formulas for determining the pension benefit. And we've had situations where we had a plan sponsor client that got in trouble with the Department of Labor because it just was not, it was very difficult to determine, based upon the language in the summary plan description, what exactly they couldn't really get to their benefit with the explanation in the summary plan description. So we like to think of it as just making sure that the benefits, rights, and features under the plan are very clear to the reader in a summary plan description.
Okay, good. Anybody else on the panel want to add to that? All right. Let's go to the next question. In an effort to reduce an employer's risk of an audit, what is the one thing an employer can do? Each of you give me one thing an employer can do to reduce the risk of an audit.
Well, I think we really highlighted about the importance of having those benefit plan documents, but you also need to make sure that you are giving those benefit plan documents to your participants and giving it to them in a timely fashion.
We recommend that our plan sponsor clients do at least an annual self-audit. Just let's go through your plan documents. Let's go checklist by checklist and make sure that you have within your reach your cafeteria plan document, your wrap document, your certificates of coverage for your insurance contracts, and then on the retirement plan side, the same thing. Because it is very easy to lose track of these documents very quickly. And so our recommendation is a self-audit. And we use some of the Department of Labor online tools, and we'll just perform the self-audit with the client and put on our DOL, IRS, HHS auditor hat and think about what would they be coming in and looking at and want to make sure that you have in front of you. We did a deal a few years ago with it was about a 3-month transaction. We asked for a copy of the cafeteria plan document, and in month 3 we still didn't have it. And so when we were looking at these issues, we were representing the buyer on this transaction. We said, well, this is the official penalty for not having a cafeteria plan document. The IRS came in and found this would be a several $1,000 penalty. And so we calculated all the ERISA legal compliance problems with the seller's documents and negotiated a purchase price reduction. So these matter not just in the context of a Department of Labor, IRS, HHS audit, which is very important, can be very costly if you don't have these documents ready, but but it comes to fruition in other contexts as well. I mentioned earlier in participants' claims, we have also gotten a Department of Labor auditor, and our understanding was that a plan sponsor was picked out because a participant called the hotline and said, I have some concerns about these issues. Department of Labor came out and sent a love letter of documents that they wanted from the plan sponsor.
And the participant complaints was what I was going to discuss, and this area draws our attention to the plans, particularly any issues that are outstanding. If you have a participant, an employee who participates in your plan and has questions, then they need to be satisfied. These questions need to be answered. They need to be provided with the information to ensure that they're receiving the benefits that they're paying for. So this disclosure is very important, just to ensure that the participants receive all of the documentation that they are entitled to explain what the plan is and what direction it takes, and if there's any deadlines that need to be met, or any guidance that they need to receive. This is a particular area that we service. We go through our customer service phase, reviewing these these participant complaints, and they are very important, and they are definitely top priority for us.
I'm just curious, Wendy, we heard an auditor a year or so ago, and they said that the participant hotline was abuzz with participant complaints, and that the Department of Labor was responsive to each call. And I'm just interested, do you have any idea of how many complaints or how active that is, and whether that's increased in activeness over the years?
I do not have numbers to provide you, but I can tell you that we have increased the number of benefit advisors that are available by telephone every day. These particular individuals open a case on each complaint that comes through, and some can be satisfied fairly quickly, maybe by making contact with the employer, requesting information from them, and then able to satisfy the employee or the participant. Others may drag on for a good while and be referred to as a lead. As I said, they have increased the number of benefit advisors in our locations, but I can't give you any numbers. I know that we have certain times of the month, that a couple times during the month, it seems that the phones just don't stop. It's nonstop. So, we get a good response from the public in regards to our communication with RESA regulations.
All right, Hannah, you want to add to one thing an employer can do to reduce the employer's risk of an audit?
I think they really highlighted it, but a lot of the things that I had said too was, thinking about having the plan documents ready, giving them to the participants, and also to making sure that you're answering any kind of questions that come in a timely manner.
Okay, so that would kind of fall in, if you look at the common audit mistake list, mistake number 2 about not communicating changes to plan participants, and possibly 3 on special enrollment rights. So it's key in your communication. I think Ann Tyler brought up about the checklist. So one of your handouts is a checklist, and you may look through that and go, that's just overwhelming to me, and I'm just going to set that to the side. But what I would encourage you to do is just use that checklist and just take a little bit of time. Maybe you take one of them per week or something like that. Say, okay, I'm going to knock this one out, I'm going to knock this out, until you're able to package that. But look through that list. That list is your friend, because it covers everything. This typically, if the Department of Labor sends out a letter, those are going to be the items that they ask for and that they're going to want to see. So you'll need to have that in the notebook or in your electronic, stored electronically or something like that.
Bob, if I could just
Yeah.
interject, one of the things that we do with our plan sponsor clients is we're going through these lists, we will memorialize the legal compliance efforts that our plan sponsor clients are making. We think that if a Department of Labor auditor, IRS auditor, HHS auditor comes in and sees this list, and this has been true, they see this proactive efforts towards legal compliance and engaging ERISA counsel to guide them through specifically customized ERISA legal compliance exercise, that mitigates significantly exposure in a Department of Labor, IRS, HHS audit. So our key is we want to memorialize what you're doing right as a plan sponsor to mitigate exposure from participants, from auditors, and so again, the key here is memorializing that the plan sponsors are taking proactive preventive measures so that we have evidence of that. We can hand documents to an auditor, to a participant in the event of a claim or an audit.
Okay, good. That's code for if you get an audit notice, you should contact your ERISA attorney.
Amen.
I'm a little more succinct than she gets paid by the hour. All right. This is a question I think probably for Wendy and Ann Tyler. If a new HR manager, okay, we have a new HR manager that comes into play, with Discover processes were not in compliance. So they came in and this is, they start looking around and they're trying to find the plan document. They find that they're just not, they know they're not in compliance. Is there an appropriate way to document putting new policies in place?
First, document. We rely on those documents to review the changes that you may have made. They're so very important in our process. But in regard to what the investigation turns up, at a minimum, a plan must be brought into compliance. And any losses that are sustained by a plan must be corrected. So you should contact your service providers, work with them on the particular issues that you may find. If there has been claims that were denied in error, then those claims must be reprocessed and paid. So that.
Yeah, so again, I would say we see this a lot. There is maybe it's a little higher in HR. I don't know with the downturn and all the tightening of staff. We saw a fair amount of HR turnover over the past decade, and that creates some real problems with respect to consistency in plan documents and processes and procedures. So this is not an uncommon issue. Firstly, I would say engage ERISA counsel that's responsive to mitigating exposure and being proactive to address whatever the compliance issues are and getting a good process in place for moving forward. And I would say, I would just caveat what Wendy said, document, but what we have to be careful of, and I think it's why it's so important to have ERISA counsel, is document what you're doing correctly, how you're complying with the letter of the law in any of these ERISA legal compliance disclosures and requirements. So I just caveat, document. We read a court case recently where the plan sponsor had documented that they didn't do it right. And so they were assessed a hefty, it was a settlement in that instance, and it was not a small amount. So the idea here is to document what you're doing right, the letter of the law, what applies and how you're doing it correctly. If these are my requirements, our legal requirements, and here's what we're doing to comply with these legal requirements.
Okay, let me do a follow-up to that, just because it makes me come to mind. So we're talking about a new HR manager, and let's say that it says, going back to 2012, and we'll say it's an ACA compliance compliance regulation, and it says that you have to have documented, say, distribution of an SPD or a plan document, and this person's coming in and there's no way to recreate that or to know that. Is the best thing to do is create a memo to the file that basically says, I took over as HR manager on this date. None of this was in place, but I've got those documents now. If you're doing that audit, does that make you, I mean, you at least see that they're doing the right thing going forward. You can't recreate the past, so.
I would agree, and again, it's the document. You have to document it and keep it in your files, make it available in the event that you are audited. We need to see the process, what happened, the turnover of the position to the new person, the fact that the error was realized and correction was made, and that you are continuing on a corrective path. You continue to provide these documents as you are tested.
Okay, great. So another follow-up to that, or do you want to add to that?
Yeah, I was just going to add, so we get these questions regularly. We had a call yesterday from a client. They said, 2009, this error has been occurring, so 8 years. How far back do we go? Do we go all the way back? And that, by the way, is going to cost us thousands of dollars to address this issue. And so one of the things that we do with our plan sponsor clients is we typically come up with 3 alternatives. And we'll talk about the most risky but least costly, a middle of the road approach, because we understand that legal compliance is important, but your businesses, and you have to allocate dollars, and there are limited dollars within these legal compliance issues. So we try to partner with our clients to come up with a reasonable, cost-effective, but an alternative that mitigates exposure. For this particular client, we said, why don't we think about going back 3 years instead of the full 8? Typically in an audit, and Wendy, you can correct me, but typically what we've seen is 3 years is kind of the window in which they're reviewing. Now, I say that I got into an IRS audit, a full-day audit with an IRS auditor, and she wanted documents back from 2002, so I caveat that. But we try to look at how do we partner with our clients to think about being legally compliant, but also understanding that these are businesses and these requirements cost money. And how do we partner that with wanting to mitigate exposure to the greatest extent that we can, but understanding that maybe, for instance, going back to 2009 was just not going to be cost feasible for the plan sponsor. And again, we go back and memorialize, well, we went back 3 years, and we're going to make good faith, diligent efforts to address the issue for the past 3 years, and then moving forward, we're on the path to compliance.
Okay, so just as a follow-up, so I've heard that you have to maintain, ERISA and COBRA benefit-related records. So plan documents for annual reports, any modifications to plan, written plan documents. I've heard 6 years, I've heard 8 years, I've heard you should take a copy and put them beside your bed and read them at night if you have trouble sleeping. So is there a set time period? You mentioned that having to go back to 2002, that seems to be, I don't know, is there a set time period? Because, it's a lot to keep up with.
Generally, we look at 6 years. It's always good to keep documents as long as you can. We like to keep them forever. I think 6 years is reasonable. Generally, our audits, we can go back 6 years, and if we have a substantial issue, we can go back a little further, or as far as we need actually. But so I would advise 6 years. If any of you have grandfathered health plans, then you have to keep all documents related to grandfathered health plans from 2009 forward. So you have to keep a record of your plan document, your SPD, the cost to the participant, the cost share basis, so that we can review these different areas to make sure that you are allowed to maintain your grandfather status. So that goes to that. But I would say 6 years is a good foundation for it.
Okay, good, thank you. All right, we have a question from the audience. This is actually from Carl Rogers, so I'm not sure who helped him write this. Maybe Dennis Stockton was helping him with this. So he's saying, let's say there's a audit, and there's a compliance issue, and there's actually a penalty with a fine. So he's saying, his question is, if the employer is contracted with a PEO, you know, the professional employment organization, so in this case, I think he's probably assuming that these employees are leased. Okay, so the employer is leasing the employees from the PEO. Who becomes liable in that situation? And as far as, is the employer still responsible for? Is the employer still the plan fiduciary in this case?
Ultimately, the plan sponsor is the bottom line fiduciary. Now, if they've handed off their decision-making to the PEO, then there could be some conversation in regard to that. I don't have a definite issue
Sure.
or a definite answer for you. It would depend on the circumstance.
So if the PEO is providing the benefits,
Right.
they could be the plan fiduciary.
They could be.
Mhm. Okay, good. Anything you want to add? Have you had a situation like that in town?
We have, and we've had plan sponsors call us and say, we're not worried about this, our third-party administrator handles this. Our experience has not been that when the Department of Labor, IRS, comes in, we actually had a client, their audit on their plan was not done correctly. It was a CPA firm. And in conversations with the auditor, she was up in Washington, D.C., she said, you know, it is a shame because the plan sponsor engaged a CPA firm, and it really was the mistake of the CPA firm. That's not who we have jurisdiction over. That's not who we're going to go after. So our assumption is always that when the you know what hits the fan, it comes down on the plan sponsor. And so we want to make sure that our plan sponsor clients are up to date and aware of all their plan documents and processes and procedures, because our assumption is that the plan sponsor will ultimately be held liable. And if you look in the administrative services contracts, that bears out. I mean, the indemnification provisions in the third-party administrator contract, some of them are pretty amazing. I mean, it's, you know, we'll perform these services, and that's it. That's where our responsibility stops. If there's any problem, if there are any legal compliance issues, any fines, penalties, not our problem. And you know, we understand that. We work with third-party administrators who are quite good at what they do. But just to reiterate, that our position is that the buck stops with the plan sponsor when it comes to an audit, participant complaint. That responsibility most likely cannot be shifted to another party.
Okay. I followed all that except there's something about hitting the fan. We'll go ahead. So this is another question from the audience. When making changes to employee handbooks, do you need to archive the old handbooks?
So in ERISA and in EPSA, we enforce Title I. So as far as what's in the employee handbook, and unless it affects the benefit plan, the description of benefits, and so forth, we do not regulate that area. You know, we advise, I guess it's going to depend on exactly what's in the employee handbook, whether or not it speaks to the benefits exactly. We have an ERISA 107, which is retention, and it's always advisable to keep your information, and now scanning it is so easy and it saves so much space that we encourage that. And it may be good to have to look back on in the event that there's an issue in the future.
Okay. You got anything else? Anybody want to add? All right. So, you can sneak up here on me. That's right. All right. So with the with Dr. Montgomery coming up here, and we're going to be talking about wellness programs, population health management. With the growing popularity of wellness programs integrated with the medical plans, what should each employer be mindful of in regards to wellness compliance?
be to make sure that the same plan is offered to all similarly situationed employees or participants. Make sure that it's offered to the same groups at the same rate or the same benefits. And also that would you provide a reasonable alternative. This is a primary issue that we see in wellness plans. There must be a reasonable alternative provided for the goals that are set in order to reach those goals. They may have certain guidance that needs to be met, but there has to be a reasonable alternative as well.
I would just say, I think wellness programs have had an uphill battle, and I think it's important that you have good counsel from the onset with respect to a wellness program plan design. And here's why. Americans Disabilities Act, and GINA, Genetic Information Non-Discrimination Act. Those two bodies of law have created a lot of problems for wellness programs. Now, they're a great concept, discounting premiums to encourage healthy lifestyles. It's a great concept, but when you dig down into how do you make those that 30% reduction in premium available, and what do you use as criteria for receiving that award, you have to be very careful that you do not violate American Disabilities Act or Genetic Information Non-Discrimination Act. And unfortunately, and this is really some larger employers have run afoul of these requirements. AARP just filed a lawsuit against a plan for violating the ADA, Americans Disabilities Act, because the requirement to receive the wellness program reward, they said potentially discriminated against those with disabilities. So I think that the key in your wellness program is being very careful with plan design and being mindful of the other laws that will apply and potentially intersect, and making sure that your plan design does not violate those laws.
In terms of wellness plan design, I know that a lot of times we look at is a wellness plan considered a participatory plan, where the fact that you're not having to necessarily reach any restrictive goals in order to receive the incentive or rewards, or is it a health contingent plan, which is where you do have to reach certain metrics or limits in order to receive those incentives and rewards. And there tends to be more of the regulation around those health contingent plans. And one of the more popular ones would be obviously a tobacco cessation plan, where you are having to look at including the reasonable alternative language, which would be the offering of attending a program instead of if you are a smoker. But the other things is it's also too that we look at is making sure that you're including those notices, and those tend to also usually kind of apply more to those health contingent plans, including the wellness program disclosure as well as the ADA notice. And then I know and Tyler kind of highlighted upon it too, in making sure that if you do have those health contingent plans, there are limits on the incentives that you can offer, which is typically usually within that 30% range of the employee-only rate. If it's a tobacco cessation, if it's related to tobacco, those limits are higher.
All right, good. Y'all did good on that one. All right, so this is a question from that comes up periodically. Can the plan documents, the SPD, everything be distributed electronically? You know, today with so many things being emailed, and you know, if you print out all of these documents that need to be, you know, I don't know how many trees we would kill, but it is one of those things. Are there rules in place to make sure? I mean, when you're looking at, I guess, Wendy, and you go in and you do an audit, and you see that the plans have been distributed electronically, is there something you're looking for? Is there anything in particular that's required by the Department of Labor on that?
I usually like to see where all of the documents were sent to each participant. So if it's sent via email, if the listing of the participants is there where I can see their names and verify, just by spot checks that these participants are receiving these documents, then I find it to be acceptable.
Okay. Because that's challenging. I mean, I see Cassie out here in the audience, and she's HR with Carroll Daniel Construction, and she's got most of her employees on the job site. I mean, these guys are out there, they're building buildings, and so they don't have access to email and things typically. I mean, so is there a solution for that type of industry, or someone where you have employees that are remote? I mean, for example, maybe the city of Gainesville has, a lot of their employees are out working, they're not behind the desk, they're not that sort of thing. So you're mainly looking for receipt of the document.
I used to look to have formerly the red receipt attached to it, but we've gone to where we'll review the email that was actually sent out. It was an effort to get the information to the participants. As far as having someone in the field that has no access to a computer, then you would have to deliver it to them by paper, and I would suggest a signatory form stating that they received it and it being mailed back to you.
Okay. Anybody want to add anything?
In going out and speaking, we've kind of talked about some different avenues of things, and have some documentation of having the employee, if you're meeting with them, and even if you wanted to have this in your employee packet, of creating and then providing you with their own personal email address that you can send, as long as it's one of those things where they are documenting that if that changes, that it could, that they need to let you know that. But also too, we've been talking a lot about thumb drives and being able to put all that information on a thumb drive. Because at this point, from what we have been told, is that even if you had a kiosk available or a computer for someone to access that information at the office, if they don't continuously have direct access to a computer, that usually it doesn't apply. So we've been talking a lot more about the thumb drives or something that would kind of provide information to be able to give them to that, and it would still be kind of more in an electronic form and not necessarily paper, but then you would also have to document that they received that information.
Okay, good. I think we have time for one more question, so I'm going to make it mine, okay? If we didn't get to your question, I apologize, but we are, we just, it's just gone by so fast. I mean, so, last question. If you look at your handout, I keep referring you to your handout, 5 most common DOL audit mistakes. So mistakes 4 and 5, when you look at being, I think it's important that you're organized with your documents, but this last one about providing too much information. And it says a common mistake is for employers, plan sponsors to provide more documentation than is requested in the hope that this will make a better impression. And I know that the Department of Labor has a memorandum of understanding with the IRS. So if they are providing information or they're in there and they see anything that's financial related, they're able to ring the IRS and say, we were in there doing this audit and you might want to look at it too. So you've just doubled your problem, right? Is that a fair statement, Wendy?
It is always best to keep it simple. If I have to dig through a stack of documents to find an answer, there's no telling what I'll see along the way. And it also prolongs the process. So just in order to get directly to the answers on that we're looking for, just keep it simple. Provide us with the information without a lot of surrounding documents. If we need additional information, we will ask for it.
All right. And Tyler, I know you have an answer for this.
Yeah, our approach is that we are responsive to the audit request, to the request from the auditor, and we give them everything they ask for and nothing more. Because, quite frankly, auditors are there to find problems and issues. And the more documents that you provide, the higher that probability goes up. So we want to be responsive to the auditors and be responsive to their requests for documentation, but we also don't want to over-provide.
I think this kind of goes back to what we were talking about with having all your information kind of in one spot. And, you know, in going out and talking with some of our clients, they would say, well, I keep that in the employee file. And I a lot of times caution in saying, well, it might be best even if you want a copy in the file, to go ahead and maybe scan all those and have them put with all the other information that you want to have and for the DOL, because you don't want to give them access to all of your employee files to be going through and possibly find something else.
All right, great. All right, we have devoted a lot of time to compliance today, and I hope you've gotten a lot out of it. I do hope that you'll take this information. I mean, we just touched, the tip of the iceberg on this, and so I hope you'll make this a priority and start getting organized and getting your documents in line. Let's give our panel a big round of applause. All right, I'll turn it back over to Dr. Miller.
All right, just a quick introduction. One of the things that we really do focus on in the MBA program at Brenau is the wellness programs. We have a pretty extensive discussion on employers' ROI or lack of ROI on generally employee wellness programs, and why, in spite of that fact, wellness programs are here to stay and generally, as I said before, a good idea for recruitment and retention of your employees. So let me turn it over to the Humana group here, and I'll let you introduce Dr. Montgomery.
Good morning. My name is John Dammann. I'm Humana's Vice President of Sales on the commercial side of our business, and I'll tell you, I'm delighted to be here today. There's been a whole lot of information, and I got to tell you, this is one of the best seminars I've been to, so I hope you're really proud of it. I think you're at 6 years, right? So, awesome. Listen, just want to make a few remarks before I introduce Dr. Montgomery. We at Humana pivoted about 10 years ago into the wellness space, and you keep hearing about health and well-being. And we've been around 50 some years, but about 10 years ago, we really recognized that the drivers of health insurance, like the cost of it, is what? I mean, what is the one main driver? Someone? Anyone? Claims due to? We're kind of unhealthy, aren't we? We're kind of unhealthy. So we've really tried to focus on integrating our products, the insurance products, with a health and well-being type of program. So you heard Brett talk earlier about Go 365. That's our branded wellness program. That's integrated into all of our fully insured plans. So, I've been with the company 27 years. I've been here in Atlanta, in Georgia, 25 of those. This is really the biggest titanic shift our company's made. And if you think about it, if we're trying to bend the curve of cost, right, of health insurance cost, the one way we can do it is to create an environment to have a healthier population. So that's really the fundamental reason that you're going to hear Dr. M, and I call him Dr. Montgomery, sorry. He lets me call him Dr. M. Before I introduce him, I want to read a little bit of information about his bio. Now, this is just a snapshot of his bio, and I know you can't read this, and there's probably about 10 other pages that I could read about him, but I'm going to just read a few little topics about him. So, here we go. So, as a recognized physician leader and executive, Dr. Montgomery brings years of experience linking health plans and providers with patient-centered strategies. Dr. Montgomery is Vice President and Market Medical Officer for Humana's commercial line of business through the state of Florida and Georgia. Dr. Montgomery received his undergraduate degree from Brown University, his Master of Public Health from Yale University School of Medicine, and his Doctor of Medicine degree from Brown University School of Medicine. He completed a family practice residency in the United States Navy, where he served as a lieutenant commander and family physician. He was also recognized as a leader in the development of evidence-based medicine for the naval medicine, for naval medicine. Dr. Montgomery is board certified family physician, a fellow of the American Academy of Family Physicians, a certified health insurance executive, certified physician executive, and a fellow of the American College of Physician Executives. So with that, please join me in welcoming Dr. John Montgomery.
Good morning, everyone, and it's really an honor to be here with you all today. And I just want to thank John and everyone for the opportunity to come and speak with you all. It's when John comments about that background, I'm so reminded and so humbled. Today is a very special day in my life. 32 years ago today, my firstborn was born. He is actually in the Grand Canyon with Mommy, but Daddy's here with you all. And so it's a total pleasure. But folks, one of the things I'm reminded of is I'm one of 11, and with all that John talked about in terms of the background, I'm one of 11. My mom died when I was 15. I watched her die from breast cancer for 2 years. Before that, my brother had gotten shot and killed when he was 9. And the night my mom died, I said to the priest in the room, if God lets Mom live, I'm going to become a priest. And I said, but if she dies, I'm going to become a doctor and fight cancer. And so to my family, that was unheard of. I was the first of 11 ever to go to college and to have that opportunity and that experience. And so when I come with a different passion. I come with an excitement. I was fortunate, just back in November of this year, I was received the American Cancer Society's highest volunteer award for volunteerism. And for somebody who made a promise when he was 15 to really fight cancer, I never knew that that's what would happen. I was the chair of the board of the Florida division of the American Cancer Society. So folks, when I come to you, I come with a slightly different perspective. I tell people I had my master's in public health. There's a colleague back up there who has an MPH, and I applaud anyone else that has that degree. It's a phenomenal degree. I was told to learn how to take care of populations before I ever learned how to take care of individuals. So I went and got that MPH from Yale Medical School. It opened up my mind to just an incredible set of what's going on in America today as it relates to population health. And so when I joined this industry after serving in the United States Navy, I was amazed at just recently about the excitement around population health. And I was like, oh my God, this is something awesome, because I got my degree in 1982. So I will tell you, it's really exciting to be here. It was interesting because Rob said I was a dessert after the meat and the vegetables, right? And so I'm back in the back and I'm writing this stuff down as a dessert because it's really interesting. Family doc, right? So if I'm gonna feed you dessert, I have to feed you some healthy dessert, right? But one of the things that's really interesting that I'm gonna talk about something that's gonna potentially stress people out, because when we talk about compliance and all the issues that we have to deal with as it relates to healthcare, the rising cost of healthcare, you can get stressed out over it all. But I was amazed when I learned that stressed is only dessert spelled backwards. I don't know how many people do that. So when you say you're stressed out now, you can just think about it. It's just dessert spelled backwards. Everything's gonna be all right. So what I wanna hopefully give you an opportunity to talk about is this backdrop for why health and wellness. And this is the stressful part of this backdrop, right? Because the reality is when I looked at this chart and the multiple times that I look at it, it gives me so much additional information. One, it tells me the cost curve is just going out of proportion. The number of Americans who are constantly dealing with chronic illnesses are pretty interesting. But the underlying 25% of young adults in this room, I'm 57, 50% of us middle-aged adults, and 69% of people who are elderly have one or more chronic conditions. And it's really interesting as we talk about this, and you're gonna hear me talk about this more and more, because the reason that employers have to be involved in this, and I say have to because as a family doc, and I don't think there's anyone in this room, I use the comment that I don't think there's anyone in here who has spent more than 15 minutes with a doctor and they weren't asleep and the doctor wasn't sticking something in them, right? Most likely you're in the operating room, you're in a procedure, something's going on because we just don't have that much time to spend with physicians. And the reality of that is, if you don't have enough time to spend with patients, or patients don't have enough time to spend with us, I used to always say when I was seeing patients every single day, if I could only get to the employer, need to be with the employer, I need to get to them. And people would say, why, doc? And I would bring out that concept about how little time we as a doctor get to interact with someone who has diabetes. I'm just perplexed to think that I can manage someone's diabetes in 15 minutes every 3 months. Some people come in once a year for an appointment. But the employer clearly has that individual captivated more than I do. In my case, John, and other cases, I'm sure those of you in this room, our employers have us 5, sometimes 6 days a week, 10, sometimes 12 hours a day. So if the employer has an individual who's got diabetes, hypertension, high cholesterol, inactivity, anything, and they have an opportunity to drive a message every single day, 5 days a week, for as many hours as that individual is sitting in front of a computer, walking through an office, they have an incredible opportunity to do what I cannot do, or any of my physician colleagues can do, and that's continually drive a message that we're going to talk about as it relates to this. Why prevention? And the other interesting thing for employers is we oftentimes talk about the direct medical costs. I'm amazed at the indirect costs that employers have to face with as well. So they're tied very heavily to this lack of productivity and the whole idea about it impacting an individual. So they're actually 3 times more likely to have indirect medical costs than they are medical costs. So the indirect, your impact in terms of your productivity and absenteeism and all those sorts of things are even more so significant. And when we look at the cost alone estimated to be about $2,000 per employee, that just tells you right off the bat, we got to do a lot to drive a message of wellness and prevention in the workforce, and you all are here to help us do that. I say I trained in infectious diseases, so if I had the flu and I coughed, I would infect every one of you all with the flu. So I'm hoping to infect every one of you all with the concept about wellness and prevention, and then we have to drive that, and you all have to go and take that back to employers, et cetera, because as you saw in the previous slide, we can't manage that health claims, that cost curve. So one of the things that's really important, and I oftentimes say to employers and others, is to really just know your numbers. And I put this up as a hypothetical company. And one of the things is, if you just look at this, and this concept I want you to keep on keeping in the back of your mind. 75% of healthcare costs, employee productivity, is affected by preventable disease. Diabetes, high blood pressure, coronary artery disease. Most of us would all tell you that those are preventable conditions. I use some hypotheticals here because I just want to dramatize the financial impact. And look at the bottom. Take 400 employees with diabetes, take the average annual cost for those individuals with diabetes, and you see phenomenal amounts of money that are wasted on preventable conditions that we have to drive messaging. And I believe the best way to drive some of that messaging is through the workforce. Similarly, you take, again, just take high stress, and again, we all know what stress is right now, dessert spelled backwards, right? When you take a high stress, you look at high cholesterol, and those two together lead to one of the things that we know is the #1 killer of Americans today, that's coronary artery disease, right? Cardiovascular disease, #1 killer. So when you take those two together, you can see phenomenal annual cost and medical cost alone. Now, what I just showed you on a previous slide, take that medical cost, multiply it times 3, and you look at that indirect lost productivity and absenteeism. It has a phenomenal impact on your employer. So we got to drive messages. I apologize for some of the interaction in the slides. When you move the technology around, there may be a little disconnect here. But all aspects of an individual's lives contribute to this positive, healthy lifestyle and well-being that we're really trying to focus. But you can see the drivers of your employer's productivity. Stress is way up there, folks. Personal and family issues, which is why we talk about health and wellness and EAP programs, et cetera, because I'm a big believer that we have to do everything we can to destigmatize EAP in the setting of driving health and wellness. Chronic medical conditions, unscheduled absences, lifestyle conditions, et cetera. And then presenteeism. But what the survey results have showed that if you invest in wellness, and you know, and we're all here in this room, that the momentum around this country to drive health and wellness is phenomenal. Why? Because Ben Franklin coined that term, an ounce of prevention is worth a pound of cure. And I threw that out like 10 or 15 years ago. An ounce of prevention in this day and age is worth a ton of cure. Folks, anything we do at the front end are going to have phenomenal impacts at the back end, and that's the message we have to continue to drive. The average medical costs, but what does wellness programs do? You know, basically, we encourage people to stay with the company. More of a third of them have fewer missed work days. Everything goes together when you get a workforce engaged in health and wellness. Coupled with that, I want you all to walk away with a few things as we get into this understanding about what you all, what some of the employer strategies are. So first and foremost, key employer strategy is know why we're talking and focusing on health and wellness. And you can break this down for any employer group to show just what these numbers are for them, multiply that indirect cost, and we can really drive more and more awareness and engagement in health and wellness. Chronic illnesses, again, 75% of our healthcare costs are from chronic illnesses that are preventable. 3 lifestyle behaviors, and I was sitting in the back of the room saying, boy, smoking, I trust that you all have heard that sitting is the new smoking. Have you all heard that? Yeah, so sitting is the new smoking. And so when you look at 3 lifestyle behaviors, smoking/sitting, physical inactivity, which goes with sitting, and then poor diet, drive 4 key diseases that we are confident of: cancer, diabetes, lung disease, and heart disease. And what do we know about that? 50% of the deaths worldwide are from these preventable conditions that we can do something about that could have a significant impact on the bottom line. If all these major risk factors for those chronic diseases were eliminated, we'd prevent at least 80% of the premature heart disease, strokes, type 2 diabetes, all that stuff would pretty much be prevented. One of the things I'm actively involved with the American Medical Association, and we're now getting doctors to write prescriptions for exercise. We're now getting doctors to write prescriptions for healthy diets, because everyone who has been in college, and most who haven't done nutrition, will tell you they don't teach us about nutrition in college and medical school. We don't know anything about it. Now we're learning significant impacts. And so one of the things that we continually want to keep on driving is this awareness about these trends, which when I saw this chart the first time, I was kind of like, wow. Because we understand, and don't mind me walking around because I know the whole concept about sitting being the new smoking, right? I got to practice what I preach, folks. So here, what we see is what makes us healthy. And people didn't really understand this. They actually thought it was access to care. Well, you can see access to care is not an issue in most cases. Genetics, 20%. What really makes us healthy is these unhealthy behaviors, or the healthy behaviors, right? But where do we spend all our healthcare dollars? We spend all our healthcare dollars on treating chronic conditions when we spend so little on healthy behaviors. That's why you all are here. So we can begin this transition to say we saw the rising cost of healthcare in the millions. We have to do something about it. And we do this through consumer empowerment, getting people aware of what's going on. Connect it all. When we talk, and you'll hear me talk a little bit more about this integrated healthcare delivery system, how we have to bring everything to bear. Predictive modeling. We can look at a population, and I oftentimes share with John and others. We can literally look at the demographics of an employer group, and just by looking at the age and sex and those demographics, we can understand really clearly where we need to put a lot of our efforts as it relates to prevention. Population health is big, folks. It's basically going into an employer group, whether they're 20 or 2,000, and I have groups 28,000 plus members. Whatever those size of that group is, we can go in and have a phenomenal impact because we can get this big data to really focus what we need to do. Coupled with that, these are these goals for health and wellness, and I'm going to just point out, we need you all, and the strategies that you all have to drive is this company focused on members' employee health and well-being. It's the DNA. It has to be a C-suite driven initiative. We have to get the leaders involved and understand that we're trying to impact their bottom line, and we can really impact their bottom line by health and wellness. But folks, what you get out of being healthy and what you get out of feeling good every day and exercising every day, I don't know if we can really put a price tag on it other than impacting our overall medical costs and increasing productivity. We have to drive this integrated strategy. We just can't talk about it. We got to be very proactive and really making health easier. And we don't do that as well as we need to. And then we need to develop outstanding member engagement capabilities. I am amazed at all the resources that we have available to us, but how few of us or engage or take advantage of those resources. I almost like want to write a little segment about take advantage of your resources, because we do not take advantage of our resources. And health plans offer a tremendous amount of resources, you all as employers do, but the employees and others are not taking advantage of these resources, and we really need to drive that. With that, we'll really educate and increase awareness about wellness capabilities, and we'll also integrate, and you all have to drive this as well with your plan. You've really got to integrate healthcare, you got to integrate health and wellness, and it all has to come together to really have a phenomenal impact. I tell people it's really important on this journey to success. And John talked about what we've learned at Humana and our experience over the years, and what we've been in the nursing home business, we've been in the hospital business, we moved from a health insurance company to a health and well-being company. We've really gotten that message. And we've gotten that message because we've done a few things that really make a difference. And this is something that you all are going to have to do as it relates to a strategy. Folks, you got to build trust first. And people don't care how much you know until they know how much you care. And when employees understand that, then you're going to go a long way. So we've got to build trust, and not only trust with the employers. We in the health plan industry, we're building trust with physicians, and we're trying to get our physician colleagues to realize the value. I oftentimes say to my physician colleagues, did you refer that diabetic patient to the disease management program? And they say to me, John, I don't know what health plan they're involved in. And I say, that's interesting, because every health plan I know has a disease management program. And I say to the doctor, you can't manage it all by yourself. And the light bulb comes on, my colleagues smile, and they're like, wow, I got some help. It's like, yeah, the help's always been there. We just have not been taking advantage of the help, right? So once we get individuals to trust us, it's like if you've ever, I love that movie Everest. I don't know how many people saw that movie Everest, but the reality is they went to the mountain, they got up to Everest, and they're able to come back, right? And so I oftentimes feel that's what some of us have done. We've experienced things, and then we're coming back and sharing what we've experienced because we know how to get there, right? We get there by trust. And once you can get people to trust you, you can get them to participate with you. Now, participation is one word, but the key element is engagement, right? We need people engaged. And when we can get people engaged, and you'll hear me talk later about silver status and getting engaged in a certain level in your wellness program, drives down phenomenal claims costs. 8% decrease in health claims costs, just having members get the silver status. So we really have to drive whatever wellness program you have. You've got to drive members to get to a certain level of participation in that program. Because once they get to that certain level of participation, we know we're going to see impacts in healthcare costs. Folks, the toughest thing for all of us is behavioral change. We all know it ourselves, we've experienced it, but we got to drive behavioral change. You drive behavioral change by getting people to know their numbers. So you introduce wellness within that facility or that employer group. You get health screening. You talk about medication adherence. We talk about all the things that we as physicians don't get a chance to talk about all the time. Once we get that trust leading to participation and engagement, and people start changing their behavior, because I tell you, I got this Fitbit on, and last night in this hotel I had 8,800 steps, and I hadn't hit my 10,000. You should have saw me in the room running back and forth. I didn't want to go to the gym because I went there this morning, but I was running back and forth in that room, and I said, well, because I'm running in a room, I said, when I was in the Navy, I used to do correctional health care, and I was amazed at how healthy the prisoners were in a small room, because they do jumping jacks, and they do push-ups and sit-ups, right? And run in place. And so that's what I was doing last night to get that 10,000 steps. My behavior's already changed. At the end of every day, I know I gotta get my 10,000 steps, because folks, I'm 57, as I mentioned, and I haven't found a nursing home in America I wanna be in. I don't know if anyone else has, but I haven't found one yet. And that's something we gotta work on, because I'm concerned what's gonna be available for us when we get 10 years older. Lower cost is big. All the out-of-pocket costs is phenomenal. We talk about prevention, and I oftentimes use an example about the flu shot. And we're getting ready for flu season, right? Flu kills 30 to 40,000 people a year, hospitalizes 300 to 400,000 people a year, but we can't get individuals to get a flu shot. And I had a conversation with a lady one day. I said, it's interesting. We're paying for you to get a $25 flu shot. We're covering the cost of the employer. But you won't go get it, but you'll spend $10 on Tylenol, $14 on NyQuil, a bunch of money going back and forth for Sudafed. You'll go back to the doctor's office, all wondering if you have the flu when the shot was free, right? So we gotta get people to understand the value of what we're trying to drive with behavioral change, because we know we'll get lower out-of-pocket costs. So if I can prevent you from getting the flu by giving you a $25 vaccination, But the cost of an inpatient ICU admission could be upwards to $100,000. It just makes intuitive sense that we gotta drive, if we're the employer paying the bill, we've gotta drive that awareness about the need for flu shots, especially when we're going into the flu season. And folks, there's no question improved health. Because the bottom line is if we can control that diabetes, control that hypertension, get people engaged, we're gonna improve their overall health and well-being. We improve your employees' overall health and well-being, I can guarantee you we're going to improve their productivity, and we're going to improve their presenteeism. And people say presenteeism, that means, yeah, they're at work and they're really working. Because there are a lot of people at work and they're not working. They're there, but they're not doing what you need them to do because of a whole host of issues that individuals are dealing with. And so that's this message about this pathway we have to get on. What have we learned? We've learned it has to be holistic. You can't do this in a bucket. It can't be in isolation. It has to be holistic. We've really got to have that outcome to be greater in overall well-being and really focusing on stress, health improvement, et cetera. That's that whole person approach. And oftentimes we forget the need to integrate healthcare with EAP, with health and wellness, and drive all that collectively together. So you have to begin to drive that culture within an organization. We've done some unique things. We've done the purpose of belonging, the security and health, and we put all that together, and then we recognize the significance of what we have to do as we get on this journey. And it has to be, again, an integrated strategy. You gotta develop a positive experience for these individuals, for employees, through that mechanism of trust. You gotta get providers and others involved. I'm amazed at what we have to do to drive physicians. I tell of a group of individuals that out of the 227 women of a big school system that, 231 women out of a big school system that got breast cancer, 227 of them did not get screened. So they missed their screening opportunity for breast cancer, yet and still they came down with breast cancer, right? So the point is that we gotta really drive this integration. They had a physician. They were fully insured. They were, as an employer, paying that healthcare bill. There are individuals who were missing a screening and a prevention intervention that saves phenomenal amounts of money. So we really have to drive that home. And it's not only money. I don't ever want anybody to think it's only about money. At the end of the day, it's about us. It's about our interaction and how we feel, and it's about people that we're dealing with. Well, but I can tell you, if you got a mental health illness and you overlay diabetes or hypertension, you just exacerbate those all together. So it's really important to really look at this from a holistic perspective. And then really, what I like the whole concept about partnerships, right? It's gotta be a partnership. We gotta really drive a partnership to get the clinical health engagement. And then we get the affordable care and improved health when we look at it from a holistic, integrated approach, just not doing it in isolation. And so these integrated strategies that really work is meeting members where they are. And I oftentimes say, folks, it doesn't matter if you're a 57-year-old, excuse me as I pinch my side to show you guys that I'm overweight, right? I unfortunately don't have hypertension, but we gotta find people where they are in their journey. And it may be that they're older and they haven't done anything, but that doesn't mean that we can't engage them where they are, right? And then we gotta support these relationships between that patient and that physician, because they all don't realize the resources. The doctors don't realize the resources that they have available to them. The members don't realize the resources they have available to them. You all as employers are paying the cost of those resources, so we really have to get people to be aware of those resources and engage them in there. And then we drive those specific and age-appropriate interventions that need to be done uniquely for your population, because it may be totally different. A population of school teachers may be different than a group of employees who work on the waterfront or first responders and law enforcement. They all have unique and different healthcare issues that we have to address, and we have to drive health and wellness to really try to mitigate some of those. I like the fact that we've done it. Humana did it on us. It was interesting. We did a 3-year study. We wanted to know if this stuff really works before we rolled it out to everyone else, right? In terms of really driving this message of health and wellness. And what we learned on our own 50,000+ employee population, it was just phenomenal. Lower healthcare costs, lifestyle risk factors decrease, and less emergency care visits. It was just phenomenal. We saw that in year 1, we had about 6% decrease in health claims costs. The following year was 10%, and we continue to see that as it relates to that. Less absenteeism, it was really interesting. We saw more absenteeism in people who weren't engaged, i.e. they hadn't gotten to silver status in our wellness program. Those were the individuals more likely to be absent from work. Interesting, right? Because not only that, we saw that when we started getting people on this health and wellness culture, and the employers were helping drive this, we saw what was happening with risk factors. So hypertension risk factors, diabetes risk factors, obesity, the BMIs. We started to see phenomenal changes and people really excited. I got the platinum status, I'm at gold status, because they saw what was happening within themselves. You will actually, there's no question, you feel better when you're healthy. So we were driving that. And then we also realized that this whole idea of people being healthy, they weren't always running to the emergency room. And so when you weren't running to the emergency room, and we all know, and you all know as employers, one of the biggest costs within healthcare is not only an inpatient admission, but those repeat ER visits. And we'll show you on a slide later that so much of it is inappropriate, which tells us that we can just keep people healthy and have a partnership with their employers, look at it from a holistic approach, we can really do a whole lot to really impact what we're seeing. So we did a 3-year study, and as I said, lower health claims costs, less absenteeism, fewer lifestyle risk factors, better utilization of outcomes, and less utilization of the emergency room folks. And that's given, that's a blanket. You all can take that to the bank and run with it, no matter what employer group you have. If you begin to drive those kinds of cultures of wellness, you're gonna see this as well. This is something that's transferable and transportable. It's not just unique to us at Humana. Although I tell people, when I was in the military, this was really easy. Because when I was in the military as a lieutenant commander and John was my hypertensive who I didn't see in clinic, that was real easy. All I had to do was call his commanding officer. And John was in my office later that morning, right? Because we had control over individuals. And I oftentimes say, you know, it would be really good if we could get employers to say, hey, the health plan nurse has been trying to reach you. You may want to give her a call or something of that nature. But we got to figure out a way. People are concerned about HIPAA violations and all those concerns. And I think they're really appropriate. But I'll show you later that if we know demographics of your employer group, we can drive a message that can be, you know, individual agnostic. You wouldn't know, because I can go in and talk about diabetes and hypertension and obesity, and I can talk about all the things that are not pointing out any individual, but I can drive a message that can make an impact and change people's lives. And that's what we did. And one of the things that we learned among all the differences that we saw, again, lifestyle, chronic conditions, and we got to work, and we're doing this at the AMA and others, to get doctors to don't be so quick to give somebody a prescription for a hypertensive. Most people, when they go in to see a doctor, their high blood pressure is because they're nervous, scared, and just got out of driving in that traffic that I came into. But when you're dealing with those sorts of things, we as doctors need to pause a minute. And we need to say, hey, John, here's your prescription for exercise and diet. I don't want you to have this high blood pressure medicine right now. What I used to do when I was in practice is I would tell individuals, if you broke your leg, I'd give you a pair of crutches, right? And I'd give you those crutches until that leg got better, and then I'd take those crutches away from you. That's how we as physicians need to be when it comes to early onset with diabetes and hypertension. We need to give people a crutch, help them out, but we don't need to have them on their blood pressure medicine and diabetic medicine for 10, 20, 50 years. My comment is, what are we doing? We're not impacting the outcome. And we're just rising the cost of healthcare. And I think creating a culture of wellness can really impact this so well also. And coupled with this, we use a different approach at Humana, and I think that I need to encourage you all to do this kind of thing in your own environment, especially with your plans. If your plans aren't doing this, you need to drive them to really do this and drive it to do it in an integrated way. Get somebody who's got that responsibility for the program. Then we use the client executives. Then we get the consumer engagement, somebody who's literally out there driving wellness. Folks, this is what we call a personal touch, right? And health plans are now moving to this personal and individual touch with individuals to really drive an awareness of what we're trying to do. And then we couple all this. So if you've got issues and problems as it relates to what we're doing, we really try to integrate all that into our concept about health and wellness. So there are some really elements to increase engagement across, and again, diverse employee populations. You all have all kinds of employee populations, and John and I were talking coming in about the generational differences within the workplace as well that really need unique strategies. So member engagement, leverage engagement models that provide this personalized insight and analytics. We gotta make it personal. It's gotta be brought down to an individual level. You got to use predictive analytics, and as I talked about being able to look at a group and talk about what they need from a healthcare perspective, I can share that with you in a moment. Motivational interviewing and the framework has to be fun. We've really tied a lot of good, fun things to our health and wellness program because we really want to change people's behavior, and we think that's really critical. It has to be at the top. And then use these wellness programs, whether you leverage expanded mobile capabilities, whatever the case may be. Everybody's got an iPhone and this and that, and we really have to drive that. I don't like to walk in the morning with the dog if I don't have my Fitbit on, and if I don't, I'm like looking at my phone and trying to put the iHealth app on to make sure that I'm at least getting 10,000 steps a day. That's that culture of wellness that I've internalized, that we have to get others to internalize as well, because it does make a difference. This is just an idea of somebody who's been diagnosed with diabetes, and how when you get those individuals involved early on through a health risk assessment and you understand that culture of wellness, then you're really able to get them involved. Nurse outreaches, and everyone has it. I say everyone should have a personal nurse. But folks, most of your health plans offer these personal nurses, individuals that you can tap into. We just got to get people to engage with them and then have that ongoing support. These nurses aren't, once a day or, basically not there all the time. You can call these individuals as you need them to help you drive this thing. And then we'll use those nurses to help us close the gaps. And I'm going to show you on another slide about the gaps that we see in preventive health care, that if you all can just become aware of some of those things, then you can use that as a strategy to really move wellness within your organization. And then, I apologize, engaging in Humana Vitality, that was the name of our exciting program before we renamed it Go 365. But the idea is, within that workforce, getting individuals engaged however you can. If it's a weight loss challenge, and we do step challenges, and we have all kinds of 100-day dashes and other things within the workforce to drive individuals' engagement, so that what their bottom line is. If you got those folks engaged and active, they're going to be more productive at work, they're going to have less absenteeism, all those other things that you can take to the bank, as I mentioned before, because it's a guarantee that you can really make things happen in that regard. And then I think it's really important with this one, and you all have all heard this. 5% of the individuals drive 60+% of the cost of healthcare. And we see that oftentimes in hospital settings, because we give so much to individuals at the terminal stages of their life, and I just wish we would put so much more on the prevention side. We know what's going to happen with a diabetic. I can look at a diabetic, see where they are, and tell them their life expectancy, tell them what they're going to be impacted with, tell them when the toe's getting cut off, when the knee's going to get amputated, when they're going to go on dialysis. And all, to me, that's all preventable. So I was in, we had a big meeting in Maryland. I was just sharing with John that we won this big contract for the transit employees health and wellness fund, and it was getting up and talking about just this kind of stuff, about what we're trying to do and engaging people no matter where they are. Everybody can benefit from a health coach. That's the awareness, that's that change in that culture. So when 50% of the individuals are healthy, they think, oh, I'm fine, I don't need anything. Everybody needs somebody to get out there and make sure they exercise. And I oftentimes use the concept, there are 1,440 minutes in the day. We've got to get individuals to at least take 10 of those minutes for themselves. Most of us need to be doing 30 minutes for ourselves, right? And we used to tell people a long time ago, walk 3 times a week, right? Forget that, man. Get out there every single day. That's a culture change. That's an employer driving a culture change. I tell John and others that I have walking meetings. I don't sit down at a desk anymore. You get up and you walk. You create a culture in that workplace, whether it's stationary bicycles or ellipticals or desks, treadmill desks. You create that workforce change, and you'll see incredible engagement. So we're engaging individuals all across the continuum, not just at the people who are already having issues in the intensive care unit, but we want to get them earlier. And these are all your employees when you think about it. You can take any employer group and you can go in and we can stratify them according to this, knowing who's costing us how much and what we need to do to get them engaged. And you'd be surprised how few people are engaged in free programs that the employers are already offering for them, and how little their doctors know about what the plans offer and what we're trying to collectively do. So we got a lot of work ahead of us, but it's really exciting. I use this slide only to talk about when we're really trying to reach out to individuals, we have to do it in such a way that we hit every cylinder. Reach out to that doctor and talk to the clinician about what we're trying to do in terms of driving health and wellness. Hit the member as often as we can with as many alerts, as many messages as we can. These guidance alerts, when anyone calls into our customer service portal and they have a question, there's always an alert. If there's a gap in care, whether it's a health and well-being gap in care, and I'll show you a few of those, we're driving messages. I gave a presentation and I said, and let alone all the member communication, I said to John, and I'll say to you all, what's missing on this slide? Tell you what's missing. You all, the employer communication. Because it gets back to my comment earlier about who has the most time with an individual. I watched the movie, The Accountant. It was a pretty cool movie, right? And one of the things I realized with that movie, The Accountant, was he had those walls which were glass with every information all over it. I went to a college, we were driving a message at a local college back in Florida, and I walked in and it was a behavioral health institute. And they had messaging all over every glass door, every glass window. They were driving a message. And I said to myself, that's really interesting. I was at another employer's meeting the other day, and I went into the men's room, and there was a sign there about the union. And I looked and took a picture of the rest of the room, and there wasn't a sign anywhere. I said, look at the opportunity employers can have to drive wellness messages. We're just not taking advantage of those opportunities. And you all need to help the employer get this message so that they can help drive down what we know to be true, which is their overall health claims cost. So that was the missing there. And so with that missing piece about the employer engagement, I'm going to share this with you because this is uniquely what we do when we go out and talk to groups to help drive this employer engagement. It's called the Plan Compass. And I say it's really driving an employer to understand what's going on. And up in that far right, you'll see major clinical conditions contributing to spend, and we really focus on that. And I shared with the dean earlier, you'd be amazed at musculoskeletal conditions and the impact, but we really don't have much to offer. And so I was sharing with her, applauding her for the physical therapy program, the occupational therapy program, other things that are being offered at the university to really drive this. And then we'll talk a little bit about utilization. I just want to give you a quick snapshot of this. This always over here on the left always blows me away because I'm amazed at how few individuals get their child well visits, and those are children under the age of 12, etc. So we're really not doing all we need to do as it relates to a culture of wellness and driving that culture of wellness, but we really have some opportunities here. Now this is the demographic data that I was talking about. And so if I went into a group, in this particular group, 885 members in general, and I look at, and I go down and I say, okay, about almost a 50-50 split for males and females. But the interesting thing is they're a 32-year-old group. So that age group tells me a lot about what I need to do. You need to really get them engaged, because if they stay with us long-term, like most people do when they're employed with a municipality, they stay long-term. So those individuals can eventually cost us a lot of money. Then I go down and I'm just looking at the current column. And then I go down and I look at the members with claims, 75%. So that means, that tells you the flip side. So when I go to present data to employer groups, I look at the flip side. 75% with claims tells me 25% didn't even get any claims, and that's preventive. Most of those are preventive claims as well. So we're not even getting that prevention message out there that we really need to drive. And then I go down to members with preventive services, 40%. So in an employer group like this, I'm saying to this employer, 60% of your members haven't gotten one preventive service in the year. We got to get members engaged in prevention. We got to drive that culture of wellness, right? And then health alerts, fully compliant health alerts. So let me just pause right there and tell you about that. Health alerts are gaps in care. And so a gap in care means that you should have something done, whether it's a breast cancer screening or a colorectal cancer screening or a certain, medication, whatever the case may be, that's a gap. But look at where we are. We're seeing only 42% of people are compliant, meaning we're reaching out to them from a wellness and a health and wellness perspective, talking about what needs to happen, looking at getting them to close the gaps. Phenomenal opportunities to get people to close the gaps in care. And then one of the things that's really exciting is here's an example of the Go 365 and the member participation. Folks, you want to get people to silver status, right? But what we see in this particular group is they've gotten started, but they're not quite there yet. Why silver status? Again, you get the silver status, we know you're beyond participation, you're engaged in the health and wellness program, and we know once you get engaged in the program, you can go ahead and basically see phenomenal changes in an overall cost of care for that individual. And John and others will tell you that we go out now with incredible rate increases and flat rate increases for groups who are maintaining and getting people to silver status, because we know we've already proved it to ourselves, so we can pass on that in terms of rate savings to others, because we know for sure if they get the silver status, we're going to see decreased claims costs. Coupled with this is another interesting chart I like to talk about, and this is a spend distribution. And if I can just call your attention to the column over here that says percent of the population and percent of spend. And it's really interesting because I like to point out the changes as individuals jump age bands, which tell you where you need to really be focusing on health and wellness. So if you look at the 19 to 25-year-old, and let's start at the females, 19 to 25-year-old females, they represent 10% of the population and 10% of the spend. What happens when those individuals get to 26 to 44? Double the population, double the spend, and you can see what happens when individuals jump age bands. So that tells me if an employer is really aggressive with driving health and wellness and getting people engaged, we could really have an impact on the cost spend for individuals as they stay with us long periods of time. We get them engaged in health and wellness, we know we can mitigate this increase in cost spend that we see. Because as people get older, we know they're just intuitively going to get more and more health conditions, as we saw earlier on. You know, middle-aged folks, we at least 50% of us have a healthcare issue, right? So if I can get individuals engaged early on in health and wellness, I'm going to mitigate anyone costing me additional money for preventable diseases if we just focused on those top 4 that we talked about, right? And so moving from there, this is another thing that I oftentimes say, the clinical program data tells you where to focus. And this is, you know, one of the things I'd like to point out. But the most important column here is the percent eligible participating, right? And so these are all programs, and you can be whatever plan you're with, they all have clinical programs. And you all are paying for them, i.e. the employer's paying for them. But it's really interesting how few individuals will be participating in these programs. And so we gotta drive participation in programs, clinical programs, focused on health and wellness, because we know clinical programs save money, right? And we know if we get people engaged in these programs, we can save money as well. Complex, chronic, 60% of people. And those are your high-cost members, right? So why wouldn't you want a complex, chronic person engaged in your clinical program? Because they're going to cost you a lot of money. I think where the employers can get involved in is just driving this one awareness about these programs, talking to individuals about what we're trying to collectively achieve. So I go in and I talk to HR groups, and one of the first things, and John and others will tell you, the first thing I want to do is get me to the members. Have a meeting, let me come out, let me talk to members so that we can take the data that we're sharing with you all and share it with them, and we can make it more meaningful and more applicable to them. I'm amazed at this program in terms of Humana Beginnings, because we see a low participation, again, health and wellness, right, driving this culture of wellness. But folks, I oftentimes submit that no one program can ensure that individuals are going to be perfect and no problems, but we can use these programs to leverage our ability to drive costs down or decrease costs. Humana Beginnings is a maternity program. If you get a mom who's involved in, who's pregnant, and you get her involved in your maternity program early on, the chances of keeping that little one in the incubator longer is greater. And if you can keep a little one in the incubator longer and longer until that 40-week experience, having delivered a bunch of babies, I hate when they come out before the time. And when they come out earlier, then we ended up putting them in neonatal intensive care units, and the cost is phenomenal. But if we can get people a culture of wellness, right, a culture of health, and changing the strategy to drive people's engagement in clinical program, you all can see phenomenal changes in the overall expenses that employers are paying, but also the overall well-being of individuals that we're taking care of as well. This is another one that's really remarkable, because I want to call your attention to the magenta color. Because the magenta color is really interesting, because that's the you look and see, these are just non-emergent ER visits, and then down here is repeat ER visits, meaning people go back and forth to the ER. As you know, ER is a very costly environment to receive care, and why we want to drive this wellness messaging as well. 32% on the ER visits and 31% of the repeat ER visits were inappropriate and unnecessary, right? And so when we go back and we're able to go and talk to employers about that kind of data, then we can really focus on driving messages, because the impact of the repeat, we had 35 members who drove 154 visits. So if you are an employer and you know that there's certain percentages of people driving ER visits, and most of those ER visits are inappropriate, we can then go back and see, what is it? What are we driving? What are we focusing on? And where we can drive an effort to really make a difference and a change. So I believe this is just some of the stuff that goes into health and wellness, because if you're healthy and you're well, you're not going to be running back and forth to the emergency room all the time as well. And then this other thing about driving wellness, and everybody's doing these health risk assessments. And when you go ahead and do these health risk assessments, it gives you some incredible information. And we're just going to, share with you that individuals, not everyone wants to exercise, folks. And because not everyone wants to exercise, or everyone can exercise, wellness being implemented in an organization, and you all driving a culture of wellness, doesn't just mean exercise all the time. And I don't want anyone to think we're only talking about exercise, but we're talking about healthy living, right? Because we know diet and obesity are big factors, right? We're talking about prevention. We're talking about fitness. We're talking about education and a whole host of others. But it's not just about exercise, because people can do a lot of things to improve their overall health and well-being and then drive down employer costs, and it doesn't always have to be focused around exercise. And then there's just this whole idea of mild, moderate, low, high, moderate, and high risk. You can stratify any employer group by low, moderate, and high, and it's basically risk factors for these common chronic conditions that we saw. So low risk meaning that people have 0 to 1 risk factors, and high means they have 3 to 4 risk factors. So we can begin to impact through a culture of wellness, driving down risk factors for hypertension, risk factors for diabetes, risk factors for obesity, risk factors for cardiovascular disease, and even risk factor for musculoskeletal conditions. We can go a long way. I tease my older friends and colleagues and patients who are over 80, and I tell the guys particularly, the weights didn't go away, guys. You just stopped picking them up. So the gym is still there, but we ain't using it, right? So we got to get people, no matter how old they are, to start lifting weights, to start being re-engaged, and don't say, I'm 60, I don't need to do that anymore. Find that nursing home that's perfect, let me know, and then I'll tell you, you don't have to do anything else anymore. But it's not out there for us, right? So we got to drive this, and we drive this, and you all drive this when we're doing these health assessments, and we get BMI data. We look at people who are pre-diabetics, and you know the number of pre-diabetics that we're really trying to impact from health and wellness are phenomenal. And then you look at blood pressure, and we got to constantly remind ourselves about blood pressure if we can just get people to understand. Strokes are a bummer. I rode in with a Lyft driver who told me that his 47-year-old wife just had a stroke. My 60-year-old sister-in-law is in the hospital, and she just had a stroke. But what was her risk factors? Diabetes and high blood pressure, right? So we know those risk factors will lead to conditions that we don't want to deal with. And now we don't know what her residual function is going to be over a preventable condition. So me, I'm hurt, but I'm also mad because I've been driving this message to them for quite some time. We've got to stop smoking. You've got to lose weight. You've got to exercise. And we can keep on driving that message, and people get frustrated. And I've had patients say, Doc, if you say one more thing to me about stop smoking, I'm not coming back to you anymore. Most doctors now are putting a note in the chart saying, talk to patient about stopping smoking. Patient refused to quit. So when that patient gets lung cancer, they're not coming back and saying, well, you never told me. So folks, we're really trying to drive that. And I oftentimes say, when we as doctors get up and we talk about things, don't ever think we're not sensitive to what we're talking about. Because as a physician, I know, and I'm a family doc, so the cradle to the grave, right? So I'm very mindful of individuals dealing with issues themselves personally. I'm mindful of individuals dealing with issues in their families, etc. But I believe if we drive this culture of wellness, and the employer has a great opportunity, because again, they have the member captivated more than we do as physicians, that we can drive this. Cholesterol, triglycerides, all the things that we know contribute to heart disease and diabetes, and we can impact these as well. So again, it's just this message. Here's these health alerts that I wanted to point out to you, because this is interesting as well. And again, you can go into any population of employer groups and see this data and really have an impact. Severity level 1 alerts, let me just tell you what that means. That means there's a significant adverse outcome could happen if we don't close that gap. Severity level 2 alerts mean it's something that's required, but it won't kill you, but you got to get that done. And severity level 3 are preventive in nature. So I'm going to walk over here and just show you as it relates to the column that I want you to focus on is the percent change column in the unique members. So if you look at severity level 1 alerts, right, these are gaps in care from most cases, and we'll look at 3s where they're preventable in nature. But 33% of the gaps have closed. So that means 67% of the gaps in care that can lead to significant adverse outcomes are not being closed. And in this particular group, we've reached out to 24 members, right? Go down to level 3, because that's prevention, and that's what we're driving, prevention and wellness. We had 30% of the people close a preventive gap. 30%. So that means 70% of the gaps in care have not been closed, and we got to go up and focus on 444 people in this employer group to really get them to close these gaps in care. That is similar to every group that you all are interacting with. The numbers may be slightly different, but we got to try to close these gaps in care. And then when we look at these gaps by disease categories, we're really able to see where there's a focus. Well, diabetes, cardiovascular disease, those 4 big diseases I told you about, you can see that we're averaging about 67% of the gaps in care never being closed. That's a message to you all to get in front of your employer groups and really drive about what we have to do in the health and wellness space to really impact overall cost. And I think I got a couple more slides, and then we'll open it up to questions and go from there. These are, again, closing the gaps and engaging the members. Preventative screening for this particular employer group was the #1 gap in care, health and wellness. Going out and saying, look, the biggest problem is we can't get people to do preventive services. We can't get them engaged. And we look at the unique member counts and we can really have something, we can do something. This always is challenging for a family doc when I see, well, child visits, consider a routine child exam for children from 7 to 11, and we still got people out here that we got to get them to get their children healthier, because you all are employers and on your health plan and you're paying for those bills as well. But we're trying to drive preventive messages, #1 gap in care for this particular group, to say we got to drive a culture of wellness with this employer group, right? Similarly, the data, the health alerts are going to tell an employer group, where do they need to focus on? What disease condition? What do I need to talk about, John, if I'm going to talk about health and wellness? What conditions do I need to drive among my employer group? Well, I would submit to you, as I did in the beginning, everyone's going to be different. Every group's going to be different. In this particular group, look at what we see as diabetes. The #2 gap, or #3, cardiovascular is the 2. The slides got out of order. But diabetes is a big trigger. And again, preventable, costly, by all means. Oh my God, the amount of money we spend for this preventable condition is alarming. As a country, as employer groups, we got to do more and more and more. And I so applaud medicine and organized medicine for really getting ahead of the curve now and saying we got to give exercises for prescription. We got to give exercises for healthy foods. We got to drive this among ourselves as well. Because putting someone on dialysis every day for the rest of their life is not the way to go. A kidney transplant averages about $350,000 to $400,000. And that life expectancy after that is just really a bummer. So driving this culture of wellness is really going to be big. And look at the other one. This was the #2 condition for this particular employer group, heart disease, right? And when you look down the list, they were all required severity levels 2, meaning we got to get people engaged. Heart disease is the #1 killer, and we got to do a lot to just drive it all out. And really impacting members. And that's for those who are concerned about HIPAA and all that kinds of comments. This is where you can go to an employer group and say, I don't need to know who the members are. I just know I need to drive awareness about diabetes and cardiovascular disease and preventive screening. Because I know those are the biggest gaps in care that this particular employer group is dealing with. So we look at those demographics, we look at the data, then we're able to drive really specific messages to that particular employer group about wellness strategies that they need to bring into their culture to really impact overall health and well-being. So, I'm going to wrap it up. We've learned a few things, and we've learned the impact. So what do we know about unengaged members? And you can take this and use it for your own employer groups as well. More absences with unengaged members and increasing health claims costs. What else do we know? Year 2, more absences, more members engaged. But if they get engaged and they're engaged, we see big benefits from somebody who's unengaged. So we really want to drive engagement in our health and wellness programs, because if we drive engagement in these health and wellness programs, we know we can have an impact claims costs. You saw the slide earlier, we can get less absenteeism, we can increase productivity in the workplace, we can have an overall healthy workplace, and the employer at the end of the day is going to get rate decreases and rate savings as a result of what they're doing for their employee population. So we're keeping a group healthier, we're keeping them on that continuum of health and well-being, and we're really driving them. And again, folks, the biggest impact that you're going to see is going to be in lifestyle-related conditions, high blood pressure, diabetes, and obesity. One more slide. And members engaged in these conditions, overall 60% lower health claims costs. And when we see lower health claims costs, and we're trying to determine what that rate increase is going to be. And Brett showed you earlier some of the projected rate increases that are going to be out there. You get ahead of this curve by really driving a healthy workforce and then bringing that DNA into that culture. You're going to really see a big impact as well. So we got to help you all. The strategy has got to be one that you all help drive. Communicating health and wellness. I think it's critical. I think we all, as physicians, know what to do on the back end. I know how to manage a hypertensive diabetic with coronary artery disease who just had a heart attack. I'd much rather manage someone earlier on in their lifestyle and get them healthy so I don't have to deal with that 5 or 10 years later. So engaged employees bring an engaged organization. You bring them together all around C-suite development, a really holistic approach to this communication. We got to destigmatize EAP because mental health wellness is as important as overall health wellness, and so we really got to drive that message as well. And then we want to help them get the big picture, lasting changes to their behaviors, because remember, trust, when you get trust, you get the participation, you get the behavioral change, you lower the costs, and then with lower costs, you improve overall health. We got to be more productive at work and at home. We got to get people to do that. It's just imperative. And then we got to develop champions. And so as I mentioned about being an infectious disease guy and infecting people, the same thing beholds when we're trying to drive champions. We got to get people in the workforce who could really champion the message that we all can't champion all the time. But they're believers. That we've won them over. They know the value. So if you can get them to be champions, there's nothing like, I tell people, I was 52 years old when I got my colonoscopy. Everyone knows that was 2 years behind when I should have got it, right? Because you're supposed to get a colonoscopy at 50. The only reason I got it at 52 was because a colleague of mine who was in the Navy, we were having clinical rounds and we were listening to everybody's name, and I heard his name and I said, well, I know him, what's going on? And they said, oh, Dr. Montgomery, he's dying of metastatic colon cancer. I couldn't believe it. I went to the hospital to see him that evening, a retired Navy captain, faculty member at a big university, and he looked at me and he said, John, I told you all what to do and I didn't do it myself. I didn't get screened. I'm 62. I'm not going to see my grandchildren. He had passed away within 2 months. Folks, I went out immediately, called my gastroenterology colleague and said, hey man, I'm ready for my colonoscopy. He said, when? I said, tomorrow. It's like, well, you need a prep. I'm like, okay, 5 days after, whatever, let's get it done, right? Reality is, I went to sleep, woke up, and I said, I was violated, didn't even know it. It's like, whoa, everybody needs a colonoscopy, Because the reality is, think about it, right? When you think about a colonoscopy, what does a colonoscopy do? And not everybody needs a colonoscopy, but everybody needs colorectal cancer screening, right? And that's the message. We've got to get people over the age of 50 to get colorectal cancer screening. You find a polyp, health and wellness, right? You remove that polyp, you pretty much eliminate individuals at risk of developing cancer. But like my colleague, he didn't get his. Fortunately, I got mine 2 years later, but the reality is we got to drive these messages. So we got to get champions. Steve was my champion. Unfortunately, he's no longer here. He taught me everything I knew in medicine as a naval officer and a Navy doctor. But we got to get people engaged as well. And so you all have to help drive engagement among our employees. I said, people talk about big data and brothers looking over you. I said, I want somebody to watch over me. I don't care who tells me, hey, you're not working enough, you're not doing this enough, because we need that, because we know what the impact. So wellness communication is key. You got to co-create this with your employees. People say, what do you mean about co-creating, John? I said, for me to tell you what works for you without asking you what works doesn't make sense, right? So I got to come into a group and employers and say, what works? Do focus groups, do lunch and learns, ask individuals. We're trying to communicate a wellness message to you. How do you want to receive this message? When's the best time to receive this message? Can you help us deliver this message? So we got to get those folks engaged. And once employees get engaged, then they'll go over to their colleague and say, Bob, I know what that chest pain's like, man, you need to go see the doc. So we get people engaged early on, and we got the trainers, we got champions, we got individuals who can help us drive this message. So I say, and people will tell you, know me, show me you care, help me, and then let's make it happen, right? Because that's what it's all about. We at Humana, I think that these are really unique for us because it's the values, and I think they're applicable to anyone. Folks, you gotta go back and you gotta inspire health, right? That's how we get on this health and wellness message. You inspire health, you cultivate uniqueness. And I hate when people say, oh, we've never done it that way. That's perfect, Let's not do the norm, because what do we know the norm? The norm showed us that first chart, right? Where we sold millions and millions of dollars and increased healthcare costs and was just doing this. So we gotta do something different. That's when we cultivate uniqueness. Thriving together means I'm not dealing with this thing by myself. We're getting champions, we're getting other people involved. Our Go 365 program, our health and wellness is a holistic family involved program, so we're really getting people involved. And you gotta rethink routine. Routine may be that you're not going to sit in a room for 3 hours and not get up and walk around, right? Routine may be that you're not going to, sit around and have a sitting meeting at work when you can go and have a walking meeting at work. Routine may be that you're going to not just sit at the desk, but you're going to bring in and cultivate having, treadmill desk stations so you can do different things, or have bikes in the workforce. That's rethinking routine. And then pioneering simplicity. We've got to make it easy for people. Can't make it hard to get healthy. You got to make it easy, and you got to do that throughout an organization. Diet, exercise, health, and wellness are all really key. So I say, in closing, let's get moving, and I'll answer any questions you all have. Thank you very much for your time. Pleasure to be here.
Thank you, Dr. Montgomery. Wow, that was, you can see his enthusiasm and passion for the subject. I love a couple of things he said. One, we have to inspire health. I like that. That's a great slogan. And who doesn't want to reduce their health care costs by 60% at the same time? Thank you very much. Well, I'm Steve McNeely, Northeast Georgia Health System. I'm also on the Healthcare Committee and the Planning Committee for the seminar. And I have the easiest job of the day, and that is wrap up and door prizes. I would like to thank you guys for attending and just applaud the fact that you're interested in this. It's very complex, but you stayed the whole time, and hopefully you learned a lot that you can take back to your companies. I also want to thank Rob and Brett, Tiffany, and the whole team at Turner Wood & Smith. They put this thing together now for 6 years and have been a major sponsor, so let's give them a round of applause. I would also like to thank David and Gail and the crew here at Brenau for providing the facilities. Perry, thank you from Rushton, Northeast Georgia Health System, Kit, Amanda, the Chamber of Commerce and Vision 2030, and ProCare RX, and then lastly, obviously, John and Dr. John from Humana. Thank you again. Okay. Oh, and one other thing too for John, will the slides be available? I did have a question about that. Okay, so if you want the slides, we'll make those available through the chamber or through Turner Wood Smith. Okay, yes, I'm going to let Rob pick these names out so you know it's not rigged, and you must be present to win. So, let's see.
Make them mad at me.
Yes. The first door prize is going to be a Yeti tumbler from Turner Wood & Smith.
Martha Spence.
Oh, she's here. Okay, excellent. So we'll set that here.
I'm sorry. Martha Spence, Merrill Lynch.
You pick it now. So this next is a car safety kit from Turner Wood & Smith.
Lisa Porter, Humana.
And then we also, which is probably the most valuable prize today, the coveted umbrella from Turner Wood & Smith. It is pouring outside.
Jill Bells, Eskimo Cold Storage.
Okay, we now have a Fitbit donated by Humana.
I may butcher this. Thomas Fabini. Sorry. Fabini?
Oh.
All right. Northeast Georgia Health System.
Okay, we now have an Apple Fitness Watch. It's the Apple White Box.
Oh, no name.
Steve McNeely.
Oh, God, that's no name either. Here we go. All right. Marcella Hart, Primex Plastics Corporation.
All right, the last is a Schwinn Adult GTX3 Hybrid Bicycle donated by Northeast Georgia Health Partners and HP2.
Are you gonna ride?
And I will ride it. It's actually right here.
Pick it up, please.
Melody Marlowe, City of Alliance.